Kia ora tātou. Kia ora, good morning everyone. Welcome. Apologies for my voice, I'm just overcoming a bit of gravel in my larynx. Welcome to Population Health Intensive. Welcome to those people online in Pukawakawa, in Waikato and Bay of Plenty and Taranaki. We're going to start today with a karakia and a mihi, and many thanks indeed to Komatua Toi to join us to open this week. This is a big week for these guys, Toi. They're going to be working extremely hard, and so it's good to get us off on the right foot. Unfortunately, Kuya, Dolly and Julia were not able to join us, so we have some support here in the form of Mataroria, who's going to be speaking, and also his sister Huhana, whom I met on Friday, who is actually she's a Member of Parliament, the Green spokesperson for health. So this is, and is Mataroria's sister. So thank you so much for coming, Huhana, really appreciate that. All right, so over to you, Matua. Kia ora.
Ka tia kera, ko tai tēnei ki te wā, kia tukunati tō tātou inoi, ko tātou karakia, kia tau iho ngā mana ki tanga te rungarawa, ngā tua ngā riki iho ngā mano, ki runga kia tātou, i tēnei ata. Nō reira, e tū tātou. E tū tātou, tō tātou himene he honore. He honore, he kororia, maunga rongo ki te whenua. Whakaro, pai e, ki ngā tangata katoa. Ake, amine. Te atua, te piringa, tōku oranga, tōku He kore he mau ngā rongo he whakaro pai ki ngā tangata o te ao katoa. Ki aro haina ki ngā teina me ngā tuakane o hene ki te atua whakahone re tia ki tō tātou ki ngi tūheitia pō te tau te whero tuawhitu. E pākoko e nei te arawhata ki te hunga wairua koutou e noho mai raka i te wāhingaro. E tia ki neki tia kei piki e tāwhaki ki ngarangi tua ngahuru. Tēnei mātou tutukua i o mātou whakamoe me te whakawhetai ahu atu mā koutou. Ki te toi o ngarangi kia i o matua te kore. E te atu e te wāhingaro te atora o ngā tūpuni huanga mano. Teniki mātou pono ngā tāne, pono ngā wahine, ngā morehu, teniki ao mate tino, teniki kia koe. Kia tuku mai te wairua maha ki te ngā kau whakaora kia mātou e kūpapātu nei. Ko mātou e nei muru nei, i au mātou hara katoa ki mua ki tau aroaro. E te atua, mana ki tia mai mātou i roto i ngā mahi katoa whakaorangia. Whakaorangia mātou i roto ngā māu i tanga nau te kaha. Nau te kaha no ki te kroore ki tau ingoa tapu rire hau. Pai marere ki rungi kia tātou e te whānau. E nō tātou. Ka tia ke rāti hei mauri ore ki te whai au ki te ao marama. A mohia ake te oranga o te tangata kaputi ki te whai au ki te ao marama. Tēnei anoa whakatauna te wahanga ki tō tātou matua nui te rangi. Kia tau iho ona nei mana ki tanga ki rungi kia tātou katoa i tēnei ata. Tēnā noa whakatauna te wahanga kia koutou hoki rā. E ngā pai maunga, ngā moana karekare, ngā wai ora o te iwi, haere mai rā, whakatau mai rā koutou. Anō nei ki roto ki tō tātou whare e tuake nei, waipapa taumata rau. He taumata, he tauira, he taumata, he rangatira, he taumata, he tunguaki. Tēnei anō whakatau te wahanga kia koutou hoki rā ngā rangatira moa popo. E kaha nei ki te whaiwhai haere tēnei huarahi o tātou ko te oranga. Kia kaha, kia maia, kia manawa nui. Anō nei a whakatau te wahanga kia koutou hoki rā e te iwi whānui, waikato whānui, te taitoke erau, ngā motu, te arawa waka, te arawa tangata, te arawa whānui. Tēnei anō ka mihi ati kia koutou, kia uru mai koutou i tēnei ata. Nā reira, he rā whakahirehire tēnei mō koutou, kia kaha, kia maia, kia manawa nui. I ako enei o ngā taonga, tuku iho, hakoro mā, akui mā. Tēnei anō te mihi ati kia tātou katoa. Tēnā koutou, ka tira, tēnā rā tātou katoa.
Te whakapono me te rani mai e tātou e.
Atu kia tātou katoa, tēnā koutou, tēnā rā tātou katoa. Kia ora tātou.
Okay. Tēnā koe te koma tuatoi mō te karakia me tō mihi. Ki ngā tauira, kia tātou katoa i tēnei wā, tēnā tātou katoa. Ko Aharangi Boyd Swinburne aho, ko aho te kaiwhakahaere, o tēnei kaupapa, whakahirahira, Population Health Intensive Week. Tēnā koutou, tēnā tātou katoa. Welcome everybody to Population Health Intensive. I'm just going to give a very quick introduction to it before we then hand over to the main course, which is our symposium. But just to remind you of what we're aiming to do in this week. And a lot of it is about thinking about health in a different way to what you would normally experience in your clinical training and in your clinical practice. It's a complement to clinical medicine, population health medicine, but it's about thinking upstream to the underlying determinants, the causes of the causes, if you like, thinking about groups as well as one-on-one, thinking about prevention, promotion, protection, about inequities, about environments which determine our behaviours, and about the systems and policies which create the environments. So we're going to get you thinking about it in quite a different way, and hopefully at the end of this week you'll be able to articulate a population health approach, demonstrate how that operates on a particular topic that you've been given. This morning we'll have perspectives from clinicians who also operate in the public health world and be able to understand the complementarity of those two approaches. The relationships with community agencies, so throughout the week you'll be meeting with community agencies and understand their role in health. And the context of health provision, funding services, which I'm sure we'll hear about from Mataroria. So it's called Population Health Intensive for a good reason. It is intensive. Your brains are going to hurt by the end of the week because we're giving you impossible things to do, like solving big problems that experts have struggled with for a long time. However, you will do extremely well, I know. All right, now I'm going to invite, we have students who are going to introduce each of the presenters this morning. So I'm going to ask Awhina Pierce to come up and introduce Mataroria. Thank you. Okay, go ahead.
Morena everyone. I tēnei ata, I have the privilege of introducing our first keynote speaker of the day. That's Dr. Mataroria Linden. So hailing from strong Northland pūtake of Ngāti Hine, Ngāti Whātua and Ngāti Wai, and the more central whenua of Waikato, Dr. Linden's resume boasts a number of pivotal foundational roles that speak for his commitment to public health, equity and Māori advocacy. An Auckland University Med School alumnus, he completed his Masters of Public Health at Harvard University as a Fulbright scholar. He has since been an equity lead for Mahitahi Hauora, a medical lead for Māori Health at Counties Manukau DHB, a board member of the Northland DHB, deputy chair of Te Hiringa Hauora Health Promotion Agency, and even co-hosted the TVNZ medical series, The Checkup. He's also been awarded the Deloitte IPANZ Public Sector Young Professional of the Year. Currently, he's a senior lecturer at UOA in medical education, the area in which his PhD research is also based, and he is co-founder of Tend Health, a board member of Te Aka Whaiora Māori Health Authority, and Pūtahi Manawa Centre of Research Excellence for Heart Health. Having had the pleasure of hearing him speak before, the Haerenga Dr. Linden has navigated to reach the achievements he has today is truly inspiring. So please do join me in giving a warm mihi to our first speaker, Dr. Matsuro.
Tūria, tūria, ki te matahau no rangi, tūria, tūria, ki te matahau no papa. Pai heretia ki te kaua tupua, ki te kaua tawhito. He kaua ora, he kaua ora. He kaua ora ki te tangata, he kaua ora ki te whānau, he kaua ora ki te iti ki te rahi. He kaua tātaki mai ki au mauai. Tūturo whiti whakamaua kia tīna tīna. Haumi e hui e tai ki e. E mihi ana ki te rangi, e mihi ana ki te whenua, e mihi ana ki ngā tāngata. O tira ka tuku mihi atu ki a rātou kua whiturangitia, haere koutou ki te pōnui, te pōroa, te pōwhakau ai te moe. A hoki mai kia tātou ngā kanuihi ora, tēnā koutou, tēnā koutou, tēnā koutou katoa. He tū tēnei o Ngāti Wai, Ngāti Hine, Ngāti Whātua, me Waikato ki te mihi atu kia koutou, e oku kuia me oku kaumātua, raurangatira mā, ngā tauira rata, ki Tāmaki Makaurau, Waikato, te tai tokero, me te moana atoi, tēnā koutou, tēnā koutou, tēnā koutou katoa. He honore nui tēnei ki te tuaki, ki te kōrero mō tēnei kaupapa nui, o te oranga o tō tātēnei whānau, hapu, iwi me ngā hāpuri o Aotearoa, nō reira tēnā koutou. Tēnā koutou, and thank you for the invite today as an opening speaker for Population Health Intensive. As I said in my mihi, I mihi to our kaumātua and our kuia. I mihi to Boyd for his leadership in public health, our time together on the Health Promotion Agency Board, and his advocacy over the many decades for public health. I mihi to our medical students, both in person and online across the regions. And I remember back to my time as a Year 2 medical student in the Rob Lecture Theatre, and my time as a Year 5 student doing this Population Health Intensive as a pūkauakaua student in Northland Te Tai Tokero as well. And so my kaupapa today, over the next 45 minutes, is to talk about population health and equity, to talk about some models, some resources, and to share a little bit about my journey into population health to hopefully help you on your way this week, but also highlight some pathways to population health equity and the role that you can take as a clinician, whether that be in public health, as a physician, as a surgeon, and across all of our specialties of medicine as well. And in talking about health equity and starting my kōrero, I share with you this whakatauki from the time of Te Tiriti o Waitangi. And it was my ancestor, Te Riki Kawati, who was the first signatory on Te Tiriti. And he said, titiro atu ki ngā taumata o te moana, kei reira te oranga mō koutou, which means look to the horizons of the sea. There you'll find well-being for the people. And he shared this whakatauki during the time of Te Tiriti out of his aspirations for the future of Aotearoa New Zealand under Te Tiriti o Waitangi and for his aspirations for the well-being of the people. But we know that those aspirations haven't been met through the frequent breaches of Te Tiriti, land loss and confiscation, and the health inequities that we see for Māori that no doubt you've heard about throughout your medical training as well. With the differences in health outcomes such as life expectancy as shown by the graph, with a 7-year on average life expectancy gap for Māori, but even more so for Māori tāne and Māori males as well, compared to non-Māori, non-Pacifica. We also know there's the inequities and the determinants of health, which no doubt you'll study throughout the course of this week, like housing, education, income, and employment. Inequities or barriers to accessing health care and differences in quality of care provided. The underrepresentation of Māori within the health workforce, which is also a contributor to these inequities. And most recently, the impact of COVID-19 on Māori communities, not only in terms of higher rates, hospitalisations, and mortality. But I also want to highlight inequities among many communities, such as our whānau, our whanaunga from Pacifica, and also for our regional rural whānau, where we see differences or inequities in life expectancy, for example, between the North Shore and the Northland, where we see differences and inequities for Tairāwhiti, places like Gisborne. And so it's also for our regional rural whānau, where there are inequities as well. Importantly, inequities for tangata whaikaha, for our disabled whānau communities, and for my Rainbow Takatapui LGBTI communities as well, who are also impacted by these inequities. And so we really have to think about what are some of the drivers of these inequities. And I share with you these reports as a resource for you throughout the week, the latest data which highlights these inequities across the life course, and for Māori, our key Māori health priorities, such as addressing kahutaurima, pregnancy, and the first 2,000 days. The importance of addressing cancer, both through prevention and screening, through to access to specialist services. Health priorities like long-term conditions with the rising rates of or incidence of diabetes, heart disease, for example, but also the increasing mental distress, mental health and addictions that we're seeing as well, particularly among rangatahi or youth. And the important health priority of paiora, which means healthy futures for Aotearoa New Zealand and for Māori. So these are some of the key health priorities, and I reference these reports for you that highlight these inequities and key priority areas. And we know that there's both a need and a right to health equity, need in terms of justice and fairness, rights under Te Tiriti o Waitangi, of which equity is a principle, but also equity as a dimension of quality of care, and as clinicians, providing high quality, equitable healthcare is a key part of our day job as well. And we know this definition, you may be familiar with it, from the Ministry of Health, that defines equity, that really looks at how equity compared to equality is unfair and unjust, because of the differential access to resources to lead healthier lives, and the need to take different approach, provide different types of resources towards equitable health outcomes. So equality on the left, where everybody has the same starting point, versus equity where we tailor our resources and approaches. But to take a step further beyond equity to excellence and justice, how about removing those barriers in the first place, particularly for our future generations? And so equity to me is not only about the outcome and the journey, which can sometimes feel really difficult and challenging when there's so many challenges in front of us, because to me equity is a process as well. It is what we do in our day-to-day work as public health and as clinicians. The decisions we make, the kind of care that we provide can be a contributor towards equity, or perhaps we're part of the problem as well. And another way of thinking about equity is that it's not a level playing field for many in our communities, because not everybody has the same starting line or the same starting point, with some having more privilege and some are having more barriers towards, for example, accessing healthcare. But also, equity is about not taking a one-size-fits-all approach. And so thinking about your project work this week, how you'll need to think about the communities and the inequities that you're trying to address, rather than treating everybody the same. And so some critical questions for us is, if we designed our services, or perhaps your project, for the least well-served, how would it be different? Are we reaching who we should be? Are we providing best practice care as clinicians, and are we contributing to achieving health equity? And I know throughout med school we often hear a lot about the problems, a lot about the stats, but I want to highlight some pathways or solutions for you to think about as a framework that I teach on, with Te Tiriti o Waitangi as the tuapapa and its principles, like equity, as a starting point for you to think about how you approach not only this week, but also how you can contribute towards population health and equity across all fields of medicine. For people, whānau and communities, for health services, for the health workforce, and importantly at the policy and health system level as well. So I'll start with people, whānau and communities. And I share with you this stunning image of Te Tai Tokiro and of my grandparents, George and Ann Davies, who lived their best lives in the far north, up near Kororareka Russell in a place called Whangaruru. But thinking about the likes of the rural far north and how far it is to access health services, thinking about Whangarei, or even getting to Auckland for specialist appointments, and then thinking about the multiple barriers in place, or those wider determinants of health that can impact on one's health, whānau health, community and population health as well. So this is quite a traditional model of Doldrin and Whitehead. No doubt perhaps you heard about it in Pop Health 111 back in the day for those who completed that course, that really looks at not only individual health, but thinking about communities, thinking about environments, thinking about the policy level, thinking about housing, education, income and employment as a key impact or determinant on one's health. So when you contextualise for people in the environments in which they are, there's multiple determinants, but also multiple solutions across these various domains, ultimately to improve population health. But to add to the challenge, the growing unmet need that we see within our healthcare system, the ability to navigate a complex health system, and even when people get to the doctor or to the health service, issues of quality of care, institutional or unconscious bias and racism that can also impact on the quality of care provided as well. But we know that there are a large number of key population health challenges ahead of us. No doubt some of your projects might relate to these issues as well, like trying to create healthier environments, smoke-free environments, with tobacco and smoking as an impact and a driver of health inequity for a 1 to 2 year contribution to life expectancy gap for Māori, and the recent changes to smoke-free legislation that can further impact on health inequity as well through the removal, for example, of a smoke-free generation. And this is my niece, Kiakialani, and she was to be the first of a smoke-free generation, born in 2009. And now the loss for her and many others of her generation because of the scrapping of the smoke-free legislation. And with my sister here today, Huhana, who I mihi to for her support today, but also as a Member of Parliament for the Green Party as well. But to highlight a number of population health challenges, vaping on the rise, vaping particularly among rangatahi or youth, as well as a key challenge for population health. And teens still continue to see illegal vaping sales in their communities. So here's another arising challenge in population health. The impacts of kāinga ora, which actually is supposed to mean healthy homes that contribute to well-being. But the key challenges for healthy housing, cold, damp housing that can contribute towards respiratory disease, ambulatory hospital sensitive hospitalizations, and the importance of healthy housing to be able to contribute towards one's health as well, and the standards that need to be met to contribute to what is kāinga ora. Finally, the obesogenic environments, which is some of Boyd's work over the many decades that thinks about not just the individual, but about the environment in which people live, in which they're exposed to marketing, which they're exposed to readily available unhealthy kai, and the targeting of particularly low-income communities with the density of fast food outlets and the rising rates of childhood obesity, with New Zealand having the third highest rate of childhood obesity among the OECD or developed world as well. So some key population health challenges. But there are many tools in the toolbox for some of these challenges, such as regulating of the environment or availability, such as reducing or restricting marketing for alcohol, but also for unhealthy kai. And those are some of the key ways in which public health approaches can be used through restricting availability, marketing, and of course pricing as well, through the use of likes of a sugar tax or sugar levy as one such mechanism. I want to also move into alcohol, and Boyd and I's time on the Health Promotion Agency board developing policies around alcohol regulation, which again comes down to availability, comes down to pricing, comes down to marketing. And we see the likes of marketing and advertising targeted towards university students through the alcohol industry and lobby as well. So another key public health challenge for us. And lastly, climate change at a global level and the impact that this will have and the inequities that it will create for our Pacifica whanaunga neighbours, but also for low and middle income countries as well. So climate change, I believe, is one challenge this week some of the groups will be working on as well. So really to highlight to you some of those broader determinants, some of those big population health challenges and the roles that we can take in public health, but also as clinicians around trying to shape a healthier environment. And so I want to move beyond that framing which came in the 90s to a Te Ao Māori framework to share with you that thinks about our cultural determinants of health, that acknowledges mātauranga Te Ao Māori, a sense of identity, of belonging, of tūranga waiwai, a place to stand, of whakapapa, of whenua, and of taha wairua as another contributor, important contributor, as indigenous determinants of health that thinks about paiora, healthy whānau, healthy people, healthy environments, across the life course for tamariki, for hapu mama, for rangatahi, for youth, for pakeke oranga, for our seniors, and for our kaumātua, our elders as well. So really think about the next generation as part of population health and across the life course as well. And so I'll share with you just a little example of how we can think about taha tinana, the physical, taha wairua, the spiritual, taha whenua, taha whānau, our connection to the land, our social relationships, and taha hinengaro, which is our social, emotional, and mental health as well, through the likes of our kapahaka among our elders. So thinking about our tikanga as a means for our well-being as well. I want to now move into health services as another pathway to health equity and population health. And thinking about how we can take care out to communities through the likes of outreach, mobile services pop up like we saw during COVID-19 response, like our drive-through vaccination clinics and testing, and thinking about care in the community rather than waiting for patients and whānau to come into the clinic room. And I remember working in Māori health, there was sometimes this term, high needs, hard to reach people or patients or whānau. When actually, if we flip it around, it is our health services that are the hard to reach, not our whānau. And so taking services out to communities, like our screening, vaccination, testing in community pharmacies, and also on our marae, for example, with our COVID-19 vaccination with former Prime Minister Jacinda Ardern having her vaccination at Manurewa Marae, for example, as different settings in which we can access and provide care for communities. But I also see through COVID the move towards online care as well, and this is through my role at Tend Health. So how can we increase access through data and digital innovation, through technology? And this is one of the few studies, kaupapa Māori studies, that looked at telehealth for Māori and showed the benefits of saving time, saving money through saving transport costs, for example, and providing more options around how people can access care. Not having to take time off work or not having to take kids out of school to get to the doctor if you can have your appointment online. While also acknowledging the challenges around technology literacy, access to devices to have telehealth, and the importance of physical assessments or in-person care as well still. So they need to go hand in hand. And hence that's been my role at Tend Health as co-founder and director of Population Health and Equity, to be able to think about how we can provide online care, which we started in 2020 during the COVID-19 response, but integrated with in-person care and our online appointments, to be able to have our in-clinic consultations, services like cervical screening and vaccination, to see the next available doctor or your GP online, but also to think about the wider care team, so enhancing primary care teams that have doctors working in a bigger team alongside nurse practitioners, pharmacists, clinical pharmacists, health coaches, health improvement practitioners providing mental health support, and medical administrators to tackle some of the workforce challenges, but also to have a wider set of skills in the care team, which you'll see in hospital, but also as you graduate and move into primary health care as well. And so reaching whānau through digital channels I see as a key way. Not all Māori are on the marae, but some Māori are online. And so promotion of screening programs like cervical screening and promotion through digital channels has been a way in which we can promote health, promote prevention, and with some examples from our Tend Health social media, 1 million views on TikTok about cervical screening, 2 million views about heavy menstrual periods as a means in which people can get access to health information which they may not be able to access otherwise. Similarly, being able to highlight other key health challenges, particularly for tāne Māori, for males, around prostate cancer screening and prevention as well. So I will share with you a short clip of one of our health promotion videos with Sam Wallace, seeing his GP at Tend, Dr. Graham Denya, for his prostate screening check, which we put online to encourage people to and raise awareness about prostate health.
And then the other thing to focus is obviously how your prostate feels. It's usually about the size of a walnut. All right. Yes, that's fine. Yeah, and just shuffle your back toward the other. Yeah, you get those hands up. That's all right. Right, so a little bit of cold jelly.
Well, that's the whole way there, isn't it?
Complete. Yeah, so you're going to be confident so your prostate feels nice and perfectly normal. Do you ever get sort of irritation or itch or it's quite common to get a little bit of especially if the blokes are really older, get a little bit of irritation around your anus. So it's fine, it's just a little bit one little area that just a little bit cool.
So I'm going to take it as a word. I've got this far until you get or I'm going to go my home. That's a
And so being able to use health promotion that's engaging, that resonates and is relevant for people as a key means beyond passing out a pamphlet without engagement about some of these key health issues. And so thinking for your project as well, using tools like the Health Equity Assessment tool, it's an oldie but a goodie, from the Ministry of Health. And to step through this with you briefly, because you may use it in your project work, and with the likes of Sam Wallace and our cervical screening and prostate screening promotion, to be able to think about how you can tailor your health promotion activities or prevention that is meaningful for communities and engaging, because there is short attention spans. And so one way in which we could promote cervical screening and prostate screening is through social media videos. And so for you, think about for your particular issue this week and the range of inequities that you might be trying to address, whether that be by ethnicity, by gender identity, socioeconomic for low-income communities, geographic barriers, or for disabled whānau. What are the inequities exist in relation to the issue? You really need to start to understand what the problem is you're trying to solve, and that might be through research, literature, and through engagement with community providers throughout the week. How did the inequities occur? What were some of those determinants, like we talked about? How will you intervene? What's your intervention or activities that are going to help tackle this issue? How could this affect inequities? How will you know that this is the right path you're taking? And importantly, how will you be able to measure it over time? So it's the importance of data and monitoring your services is important to show that you're closing the gap as well. So the Health Equity Assessment tool is a tool I wanted to share with you this week, not only for your project, but also for future health work for addressing inequities too. So I'm going to move into the third pathway, which is the health workforce, which includes increasing Māori and Pasifika health professionals as a key step towards health equity, but also the importance of culturally safe care that we need to provide as clinicians, and for future leadership of public health and population health as leaders. Not everybody needs to be a public health physician, because everybody can be a leader of public and population health across medical specialties. And so I want to share with you a little bit about my journey into population health, coming from Tangaroa College in Otara, South Auckland at the time, as a year 13 student with my best mate Michael, and we wanted to become doctors. And part of that pathway was coming to the University of Auckland through the MAPAS program, and as a pūkauakaua fifth year medical student. But I remember I wanted to be a doctor, and I want to be a doctor, but I was also interested in wider health. But I didn't quite know what that looked like. But I found in my first year and throughout medical school, I was really interested and passionate about population health. And I was good at it versus chemistry or anatomy and others. So in my group of friends, I was the population health guy, and then others would be the anatomy and physiology and other fields. So part of what I found is thinking about what you're interested and passionate about and what you're good at as well as a means. So for me in my day job, it's not like a job, it's part of what I do and I enjoy, and I happen to get paid for the work that I do as well. And so that's what I've really enjoyed coming into population health. And to graduate in 2011 as a first year health officer at Middlemore Hospital, and for 4 years as an RMO, while also doing my PhD part-time. And it was once I stepped off the ward round, just for a moment, that I started to see all the other activity that happens in healthcare. It happens in Māori health, Pacifica health, health promotion, diabetes programs, mental health, aside from clinical care, which I didn't really see when I was providing clinical care in the hospital. And that was really how I discovered more and more of my interest in public health, which is why I wanted to embark on my Masters of Public Health. And I thought, I want to apply to Harvard and see if I can go and experience a different country and a different population health program as well. So this was our class of 2016. And the motto on the building is powerful ideas for a healthier world. The powerful ideas that we all have, that we can all action to contribute towards a healthier world. And it was among many fields of medicine here, among surgeons, among physicians, among medical students who were doing their masters as well as other health professions as well. So doing my academic year as a Fulbright Scholar and a Frank Knox Fellow to be able to attend and do my masters. And it was there that I discovered the many fields of public health. I mean, a bit like surgery, where I did a lot of my RMO years, there's upper GI, lower GI, vascular health, cardiothoracic, breast, endocrine. And there's fields of public health as well. It's not all the same. There was health policy, social and behavioural health, global health, health management, environmental health, and epidemiology. And my major in my public health masters was health policy and health management. But also within Aotearoa New Zealand context, there's Māori health as another field of public health. There's academia, there's the Ministry of Health, there's Te Whatuora Health New Zealand, there's community public health. So just to share with you the wide opportunities available in public health. And for me during my masters, a real highlight was doing my practicum at MIT in data science and doing a course in entrepreneurship and health IT at Harvard Business School as part of my international experience during my year at Harvard. But it was also where we confronted a number of public health issues. I was there during the election of Trump and Hillary Clinton, got to see both rallies and the eye-opening polarization of politics in the US, and particularly when it comes to healthcare as well. So I was literally studying health policy. Trump won, and then the Affordable Care Act gets overturned. Obamacare gets overturned. So politics is a public health issue. Again, this was going to a department store in the kids section having a McDonald's, which identifies the commercial determinants of health at play in the US. Like you're literally in the kids' clothes, and there's the McDonald's right there for easy access to fast food and the obesogenic environment. Going for a salad, I thought, at it's called the Cheesecake Factory. That's an 1,800 calorie salad. And then you'll have dessert, 1,200 calorie cheesecake, and there's your 3,000 calories in your meal. And you think, oh, I'm just ordering the salad healthy option. And so the density of high calorie processed food, coupled with the physical inactivity and the environment in which people are surrounded, is part of a key public health issue as well. Guns as a public health threat. We had to think about it less here in Aotearoa, but in the US, it's a public health issue. And it comes down to, again, access and availability of weapons, which is something that I hadn't thought about or seen here as a public health issue. And the big debate, particularly in 2016, about vaping, which was new on the scene, and whether it would be a lifesaver or a smokescreen. And to me, vaping is less harmful than tobacco, but not harmless. But it was the real split in public health about how we use vaping to tackle tobacco smoking. And always the tension between abstinence and harm minimisation approaches when it comes to alcohol and other drugs as well. So it was my graduation day after a year doing my program, and the real highlight for me was my grandma, who you saw earlier, travelling all the way from the far north, good 20 hours of travel, to be with me and my mum and my partner Dixon at the time, and to fly the Māori flag at Harvard with the New Zealand flag as part of my graduation day. But it was a real turning point for me to graduate and think, what comes next after graduation? And that was where I came back to Aotearoa to finish my PhD and become a senior lecturer in medical education, but to also embark more into population health. So after 5 to 6 years of clinical medicine, really moving into population health from this stage on. Like working in the Māori health team at Counties Manukau DHB, especially on Māori child health, research and trying to create vaccination campaigns and programs to improve childhood immunisation rates. To be able to have the call of home and work in Northland, Te Tai Tokerau during the COVID response, which was, again, I think where a lot of people started to realise the importance of public and population health. But part of that work as well was around how we can take public health measures like testing, staying home when unwell, mask wearing, contact tracing, social distancing, but weaving it into our tikanga to stay safe on the marae. So using those public health measures, but bringing it together to provide guidelines for our tangihanga to be able to hold hui and to keep whānau safe and to provide those outreach care into the community models with the likes of Ngāti Wai Trust Board, for example. So it's important to think about your actions or interventions and how you relate it into cultural or social norms as well. So that was a journey in through the COVID-19 response. And during that time was to start to co-host a TVNZ health show called The Checkup, which was primetime health promotion. So literally my week was primary care Monday, Tuesdays at Tend in Northland, Wednesday, Thursdays at the university, and then a TV show on Friday, which was just a way to think about the variety in your week and the many different possibilities in population health that really fills my cup and makes it a really exciting week of variety and different roles that can be had. And so the checkup was with other GPs and emergency doctor to promote health promotion messaging during prime time. And this was just one short clip about the importance of vaccination, particularly measles, from the checkup show.
It's highly contagious, can be life-threatening, and has no cure. It is also easily preventable with a vaccine. A vaccine with a 99% success rate after 2 doses. Why then are so many people suffering? It's estimated that 400,000 Kiwis could be at risk because they are not fully vaccinated. 2019 saw one of the most significant outbreaks in recent years, with 2,191 confirmed cases. Paediatrician Dr. Simone Watkins was at the time.
I worked during the outbreak in South Auckland, and it was just devastating seeing these babies being in hospital for weeks at a time, and there wasn't much that we could really do but support these families and the babies while they kind of got it out and their ongoing built up that community.
And so just a short clip about the challenge of measles outbreak back in 2019, and now we're confronted with record low number of vaccinations, which creates a risk for us of a measles outbreak. And of course, coming into wintertime now with influenza, respiratory illnesses and COVID, just wanted to play that clip to highlight the importance of public health measures like vaccination, screening, staying home when unwell, masking, testing, etc. So I just now want to move into the final pathway which I see towards health equity is at the health system level. And this was also my journey into health governance as a member of the Health Promotion Agency and also as a board member of Te Aka Whaiora, the Māori Health Authority. And we know at the health system level the many challenges, no doubt you've seen in the hospitals, in the clinics, workforce shortages, increasing demand because of an ageing population, long-term conditions, increasing numbers of population groups as well, and the limited resources. And of course, with Budget 24 out on Thursday, we'll see how much investment goes into the health system. And so at the health system level, those are some of the challenges, and hence the basis of the health reforms with the establishment of Te Whatuora Health New Zealand and Te Aka Whaiora, a Māori health authority. to be together on this journey as a wakahaurua, which means a double-hulled canoe, that we were set up in partnership to be able to go forward towards Pai Tawhiti, or the vision of Pai Ora, Healthy Futures for Aotearoa. And it's been on this wakahaurua together, Health New Zealand, Te Aka Whai Ora, to be able to tackle the health system challenges for population health and for Māori health. And for Te Aka Whai Ora, the establishment of a Māori Health Authority, which has taken many decades in the making, with the recognition through the multiple treaty breaches and the lack of recognition for tino rangatiratanga or self-determination, mana motuhake of Hauora Māori and health, which has been reported throughout research and the health system review as well, so the basis for a Māori Health Authority. And I honour those who led the way, the pioneers of Hauora Māori, over the many decades who called for a Māori Health Authority to tackle these challenges of health inequity. So I stand upon the shoulders of many rangatira, the likes of Tā Mason Jury, Paparangi Reid, the Y2575 Waitangi Tribunal claims that led to this moment in time, and for me as a board member. So he honore nui, it's been a real privilege in my life and as a health professional to serve on our board of Te Aka Whai Ora. Ultimately, to whakahiko i te oranga whānau, which means to enliven the health and well-being of whānau, and to be able to, through Te Aka Whai Ora, set policies and strategies like the New Zealand Health Plan, and like Pai Tū, the Hauora Māori strategy. For those of you interested in policy, these are some of the areas you can influence at a health system level. But also to commission and fund kaupapa Māori services has been another function or lever for change of Te Aka Whai Ora, and to be able to establish iwi Māori partnership boards across the regions and within their rohe o takiwā to elevate whānau voice into our health system, for example. Ultimately, so that as Kingi Tāwhiao said in the tongikura, or the proverb, e kore tēnei whakaoranga e huri ki tua o aku mokopuna, so that our mokopuna of future generations can inherit a better place than we have inherited. And so I just want to share with you a short video about some of the mahi of Te Aka Whai Ora from our CEO, Riana Manuel.
E karema, your dedication, commitment and huge contributions to improve the well-being of whānau have already made a massive difference. In such a short amount of time, we've managed to achieve things like more services designed by and for Māori, increased funding for our Hauora Māori partners, significant investments in tamātanga Māori and rongoa Māori solutions for the first time ever, greater funding to grow and support a health workforce that reflects the community it serves, and formal recognition of our 15 iwi Māori partnership boards to help give voice to whānau and Māori in their role whilst managing and monitoring for local outcome. Te Aka Whai Ora originated from the advocacy of some of our greatest rangatira and leaders over generations and across the motu. It was the culmination of many years of whānau voice, action and activism to bring the health outcomes for Māori up to the same of those of non-Māori. Our commitment to bringing transformation, change to the health system is bigger than any one institution. These aspirations will continue no matter what lies ahead. They live in the hearts and the minds and the actions of those who have been a part of this journey, but mostly in our whānau and our communities. On behalf of our board and the executive leadership team of Te Aka Whai Ora, I just want to say that we appreciate your commitment to this kaupapa as we have travelled our way on our whakahaurua through the various motere, through the pikinga menga hikinga. You've been at our side, you've held on to your boy, and we appreciate that deeply. E mihi atu ana, kia koutou katoa, kua mahia ki te whakapiki tō tātou hauora me tō tātou orana i roto i tēnei kaupapa. Mauri.
And so I just wanted to share with you a little bit about the journey of Te Aka Whai Ora so that you can hear it at this stage of your training and the story and the aspiration that we've had, because we know that it's now being disestablished. So to tell that story of the partnership, but also the disestablishment to Health New Zealand, Te Whatu Ora alone. But as Dr. Rawiri Jansen says, who'll be speaking to you later today, our kaupapa is enduring, because with or without Te Aka Whai Ora, the mahi will continue. Because we're all on this waka, together we all have a role to play in population health and equity for Māori as well. And so while the waka haurua is no more for Te Aka Whai Ora, it's all part of the journey of haura Māori, the piki me ngā heke, the many challenges ahead. And as Tāhemi Henare once said, kua tawhitike tō haerenga mai kia kore e haere tunu. He nui rawa o mahi kia kore e mahi tunu, which means we've come too far not to go further, and we've done too much not to do more. And in closing, as Tina Ngata says, the road is marked with many disappointments, but we must rise back up, set our eyes on the goal of self-determination, and continue the march to justice for our whenua, our land, our moana, our seas, and our mokopuna, our future generations. So, in closing and in summary, we all have a role to play as tangata tiriti, tangata whenua, and as pro-equity allies to turn the tides of inequities. Ultimately, it's our people, our whānau, and our communities that matter through addressing those social determinants of health. Improving access to health services, improving cultural safety within the health workforce, and as current and future leaders in population health, no matter which field of medicine you embark on. Upholding te tiriti o Waitangi at a systems level is important to ultimately achieve the aspirations for haura Māori, Māori health and equity that can be taken forward by all of us. Nō reira, tēnā koutou. Thank you very much. Kia ora. Ngā mihi.
Emotion felt with the disestablishment of Te Aka Whai Ora is a huge burden for those of us who support better Māori health outcomes. And so thank you Mataroria and the team. And it was beautiful to have Rihanna's video at this time, as Te Aka Whai Ora will close on the 30th of June. E te whānau. It's a heavy burden right now. Kia ora.
Kia ora. Kia ora koutou.
Thank you very much, Mataroria. That was inspirational and stirring, and I'm sure everybody appreciated where you've come from and how you got to where you are, and the many aspects that you have applied your skills to try to improve health equity, and particularly Māori health. We've got a good amount of time for discussion. I've got a whole pile of questions for you, but I'm going to we've got to have the chance for the students to ask questions. So those of you who are online, there's a Q&A, the chat box, yes. If you've got any questions, please just put it in the chat, and Anna is going to monitor that and we'll bring your questions through. So please, Mataroria raised a whole number of questions and issues, and we want to have some discussion about those. So please let me know. What's that? Oh, he's got a mic on. Oh, students. Okay. Well, if we can't, if you want to ask a question here in the auditorium, put your hand up. We'll get a mic to you, or if you want to shout it out, I can just repeat the question. So open for questions and discussion. Yeah, please.
First of all, thank you for such an informative and amazing lecture. I think I might carry a few voices here when I say that young people sort of feel a bit helpless right now in hearing all of this news and thinking about the causes of the causes. One example you said with the respiratory illnesses, and one aspect is catching a bug and the cold housing, and so a naive approach would just be, okay, fix the housing, but then we have the policies that incentivize luxury apartments, 2 to 3 bedrooms, rather than multi-generational community living that would really kind of be a kaupapa Māori and population health approach. My question is, what do we do as young people? Because we feel like that gap between where we are to actually making these decisions that we know would benefit everyone is so big in our heads. Apart from just voting, what can we do here?
Yeah, great question. Thank you for the question. I'll just repeat it just in case for those who weren't able to hear it or are online. And big question, which was really about so many challenges and so many issues at the moment, thinking about healthy housing policies and what is the role that young people can take, and perhaps in your role as a medical student currently. And I think that's on multiple fronts that you can take. And that might be, firstly, thinking about in your own way. And so being able to finish your training, graduate, and going into your field. I'll share one example. I remember at one of talking with other students, we were like, do we go into public health? Do we go into general practice? What is the biggest difference that we can make? And I said it's all of the specialties, no matter which field you enter into, you have a role to play, whether it's now or in the future as well. So it might be around advocacy that you might take within your own groups as medical students. It might be about the research or the project work that you do. It's on multiple fronts in which you can contribute in your own way. So that's what I'd highlight for you all, and especially across the regions online as well, within your own area, within your own hospital. And how I think about health equity is it can be at an individual clinician level, as a team, within a department, within an institution, or at a system level. So really think about those levels in which you can influence, because it all feels really big and daunting. But in your day-to-day with colleagues, how is it that you can help or contribute or advocate within your clinical team, within your department, as a university, or within your hospital, at the policy level. So those are just different ways to really think about the role that you can have. But like I said, it's in the day-to-day. Everybody can take a role, and sometimes it feels like we might not have much of a voice, but actually we do in our own way, in our own influence as well. So those would be just a couple of ways to think about the challenge, but also the opportunities.
Yeah, and the doctor's voice is a privileged voice. So never forget that what you say is actually critically important, not just to your patients, to your friends around you, but wider as well.
Thank you.
Kia ora, thanks for that great question. Got some further questions from students? Keeping an eye online. Okay, while you're thinking of your questions, please bring those up. I've just got a couple for you. So Matarori, I know it is quite emotional and depressing what's been happening recently, and I know that Māori and Māori groups and organisations are feeling battered from all sides, and Te Ako Whaiaro was really a kind of a beacon of hope where, as you said, it's been kind of decades in the making. But from the outside, a lot of people will be thinking, well, what have we lost? I mean, these people, they've just gone into Te Wharaora, they're doing the same job, but they've gone into the Ministry of Health. We've lost a whole lot of bureaucracy and duplication of resources. So what's the difference? The people are still there, they're still funding some programs, so what have we lost?
Yeah, great question and great challenge. And it really has been literally going from two organisations renamed into Health New Zealand, Te Whatuora, but that's actually not the same thing.
Yeah.
The sum, what's that saying? The sum of its parts aren't the same as what it is now, in my view. And I respect our Te Whatuora Health New Zealand board colleagues and the team, and for our kaimahi or staff who have moved across. But you have less decision making and influence. You have less control over funding and over policy, over the health plan, over the strategies. So it isn't the same. And also, I'd argue, less accountability.
Yeah.
Now it's an even bigger organisation, 80,000 workers. versus a Māori health authority with 250 staff and a board who's accountable. And so it's not the same as having what is ultimately some power over a space for hauora Māori that's now being lost. But importantly, I have to also support those who are still on the waka, who have moved across, like Riane and the team, to support them in their new role and within Health New Zealand now, Te Whatu Ora.
Yeah, kia ora. Other comments, questions, folks? Yep, one up here. Just shout it out and we'll repeat it.
Just a question for yourself. If there's one population health intervention you could introduce today, what would
Good question. Because there's a few.
Just repeat the question.
Oh, sorry. The big question was, if there was one population health intervention that you'd introduce today, what would it be? Well, I'll give three. And so obviously in terms of smoke-free, that we know is a real important contributor to differences in life expectancy, increasing and lowering the bowel screening age for Māori and Pacifica, because there's clear evidence that Māori and Pacifica have an earlier onset of bowel cancer, and so the importance of bowel screening, and improving vaccination rates is key as a key public health prevention measure. So those are within the realm of public health, but if I were to wave a magic wand, it really would be about how we can tackle those bigger challenges around inequities, around education, income, employment, around housing. Those are really the underlying, at least some of the underlying determinants. So I'll probably come up with four, but those would be some key population health interventions that could be action today.
That question was put to the health spokespeople before the election. We had a Health Coalition Aotearoa, which I co-chair, held a symposium with some of the political leaders, health spokespeople, and that question was asked by Corin Dan, and we got three different answers. The answer from Aisha Verrill was the biggest thing that we could do to improve health in this country was to honour the treaty. From the Greens MP, which was Chloe Swarbrick, or she was a spokesperson, the biggest thing she said was to deal with poverty, reduce poverty. And from Shane Reddy, who's the current minister, his was to sort out health workforce. So different perspectives.
At different levels.
At very different levels. But I thought that was quite interesting and revealing, a question to those party leaders.
I thought I'd just highlight with your example, two ministers of health who are doctors, one from Auckland, one from Otago as well, Shane Reddy and Minister Verrill. So very much thinking about workforce and pathways for you. There are many different possibilities, whether that be at the politics level, or within your field of clinical medicine too. But great example you gave of two doctors who have been or currently ministers of health as well.
Kia ora. Anything you just keep checking? Okay. I'm going to ask you another difficult question, Matarori, and it might be a little bit of a challenge for people working in the health system to deal with and understand, and that's what you touched on, called institutional racism. And what does that actually look like, and how do people recognise it? How do you deal with it? It's kind of a bit accusatory of the people working in the system, so people feel pretty defensive about it. They're being accused of racism is not a happy space to be. So, but what is it, and how do you recognise it and manage it?
Well, firstly, there are different forms of racism. Interpersonal racism, which is more at the individual one-to-one level. Institutional is really looking at the systems and structures and ways that have been put in place that privilege some and discriminate against others. So I always say nobody wakes up in the morning to do a bad job. And so it's important that when we talk about institutional racism, it's not at the individual clinician to patient level, but it's actually in the environment and the system in which you're working in, which has really been designed in a colonial Eurocentric way, which is designed to benefit some over others. And so that's the institutional racism, is thinking at a system or structural level. And how to address that is in many ways is really trying to, like we've seen over the past few years, reorientate and redesign systems that are more inclusive, that are less discriminatory and less racist, to be able to address some of these key equity issues. So Te Aka Whaiora is one small step among the many in order to try and change systems, structures and institutions like the health system as a means to addressing racism in health. I'll just add, which I didn't have on my slide, it was Ashley Bloomfield who actually identified previously as racism as a determinant of health in itself as well. So thank you for the question, and I thought I'd just share the different types of racism, the system, the structures and the institutions in place that privilege some and discriminate against others as a means of racism. And take down different pathways and how to fundamentally shift systems in order to be able to address the institutional racism as well.
Yeah. Thanks, Mataroa. It's a tough issue, and it's going to take some time to get those systems in place. And some of the things that have been done to address that, I mean, different rates of access to vaccines or screening or something like that as part of recognition of that. Is that right?
For sure.
Yeah.
Yeah. And so COVID response and the inequities that arose is one example of an institutional racism level about how it became more inequitable for communities like Māori and other communities as well.
Yeah, and your example of hard to reach patients versus hard to reach services is just a different way of thinking about it. And it does start with the mental model. Yes.
Yeah, thank you.
Thank you for your report. I guess stepping back, a lot of these initiatives, a big problem, a key problem is funding, being able to actually get a lot of these kind of off the ground. So what I'm wondering, and what I think we don't get a lot of exposure to, is how is that process facilitated? Like, what is there a sort of streamlined process by which organisations or at a wider level do actually get funding for this program, and what sort of barriers are in place if there is a streamlined process for that?
So we had a good question, kia ora for the question about funding. And interestingly, with Budget 24 coming up this Thursday, that's where we'll see how the funding, health funding, Vote Health, but also other policy issues as well in terms of housing, transport, and social welfare or work and income support as well. So just a quick summary of how funding works in health. Starting with Budget 24, for example, is that there is a budget bid to be able to put in the request from Cabinet. How much will go to health? It's about 25 billion currently or so, give or take. And within that budget bid, there's then what's called appropriations, which some is for primary and community care, Haura Māori appropriation, hospital and specialist services appropriation, workforce funding. And so it's really at the Cabinet level that those decisions are made about how things are funded. So you'll be very aware of the strikes on at the moment among RMOs. And just to say that it's not in Te Whatuora Health New Zealand's camp alone, because the funding comes from government. And so how the government prioritises which services, which providers, and which workforces to fund, that's where those decisions are made. And so in this instance of RMO pay, it's beyond Health New Zealand Te Whatuora alone, because it's a government decision to put more funding into the health workforce. So thought I'd just share with you the kind of processes of health funding and how that works at the government level and how that's then distributed. Hopefully we'll see more shift from hospitals into primary care. because we know primary care is underfunded, Māori health services are underfunded, because the hospitals swallow up so much money to run the hospitals, but we know through effective population health prevention and primary care, we can prevent more admissions into hospitals as well. So hopefully that kind of gave you a few examples of the funding.
Supplementary question.
We've got another question.
Just in terms of funding, can you speak to the inequalities that exist for workforce and delivery of services between NGOs and Te Whatuora?
Yeah. So another question came in terms of pay inequities between primary and non-government organisations and Te Whatuora, the hospital. And so I'll give you an example which is well known. The pay settlement for nurses. Now, all nurses need to be better paid, but usually it goes to the hospital DHB or Te Whatuora nurses first, which then creates a wider pay disparity or inequity compared to community nurses who aren't funded in the same way. And then for Māori provider nurses, even more so as well. So that's what tends to happen. With the RMO settlement, it'll raise the income of doctors working in the hospital district health board Te Whatuora system, but that's not going to necessarily address pay for other doctors in the community as well. So just thought there's quite a balance that needs to be thought through when it comes to pay settlements, but ultimately it's trying to lift everybody to recruit and retain our health workers is key, and that sits at a government priority level.
Questions, hands up. I'll still go through. Yep, over here.
Okay.
Kind of to add on to the previous question.
Yes, of course.
I'm realising how ignorant I am about this space. How do these different groups all interact, and how do they influence health policy itself? Because I understand from my limited point of view that Health New Zealand Te Whatuora, for example, can't necessarily pass a bill which would be able to make some of these differences. But how much say do they actually get in Parliament?
Great question. So again, the question was about the different influence and roles that the health authorities play, if that was the main question, and then into NGO space as well. So I was always really interested in health systems and health services and designing models of care and designing at a service level. And how it works at the health authority level is you've got the Ministry of Health, and they set policy, they set strategy. Health New Zealand Te Whatuora can't set policy, can't set strategy. They're the operational arm of the health system. And so they're not able to set policy themselves. The Māori Health Authority had both policy, funding and monitoring of the health system. And so coming back to Boyd's question earlier, what's the loss? Well, the loss is being able to set policy, set strategy, and now our team's gone into Health New Zealand, you've lost that ability. And so that's really a key difference, but also to think about, you've got policy setting, strategy, and the delivery through Te Whatuora, but it's a different space again for communities, for primary care. And that harks back to about 75 years ago with the Social Security Act, which was to create universal health care. But what happened is that the primary care doctors didn't go along with hospital services to have universal funding of healthcare. So we've got a public-private model, and that's originated from that passing of that legislation decades ago, which created free healthcare for when you present to the hospital, but a copay when you go to primary care. And so the incentive in place through a system design means that more people go to the hospital fundamentally.
So just on that, Mataroria, you've experienced the US and its health system, which is always held up as a hell of a good way to burn a whole lot of money with not a lot of good health outcomes. But there is always the push, isn't there, between privately funded and publicly funded health services. And it's always a bit tempting, I guess, to say, let's just let the private sector do this, and because they can do it more efficiently and get it done with, and we'll have more hips or whatever. So can you just talk about this balance of public and private funding for healthcare and the risks and the balances that we need to be aware of?
Yeah, and that's something that I saw in the US among studying with other colleagues from different health systems. So a Canadian surgeon said to me, oh, we don't have private healthcare in Canada. And I'm like, wow, you know, like it's a different paradigm. Whereas here in New Zealand, we've studied health science and population health, and it's our way of kind of running the health system. So there's completely different models. Models like Singapore it's a health savings account model. And so you have a health savings account that pays towards your health care. So different models. Don't just think there's one size fits all model. And in the US, it's an extreme example of private health care, which is great for those who have health insurance, but not great when it comes to the cost involved for those who don't have coverage. In New Zealand, it is a mixed model. Publicly funded primary care that's privately delivered, private hospital or private health care. And I think the key issue that I've always raised is about how we can have the balance across both. So to me, it's not about universally publicly provided healthcare, but to make sure that we have an approach that keeps both in mind. Because, for example, to keep up with wait lists in the hospital, a lot of it's outsourced to private. But if you outsource more care to private, like hospital surgeries or diagnostics, then it might drive more of our health workforce into private, and then you have less public services available. And so it's about making sure that you're deliberate about both public and private health care as a means, because there can be perverse incentives in place if you're not careful about how you look at that balance. So, like I said, different examples from different countries. It's not the same everywhere. And to think about a different paradigm in your studies this week and throughout medicine, because there are other international examples out there of how health systems are designed, funded and delivered.
And the more people who go into the private healthcare system tend to be the better off, and therefore they're not experiencing the public health system, they're not there to be a champion for it or call it out or whatever, and so it does take us down a two-tier approach, and you lose a lot of value and advocacy and support for the public system, right? So it is a bit of a challenge. We've kind of got the model that we've got. Doesn't mean to say we can't change it, but changing these fundamental things is actually a bit of a challenge. Even thinking about oral health and dentistry and things as well.
Didn't even talk about oral health. There we go.
Because that's
not funded,
privately funded, and that's just a whole different different model.
Public health issue.
Yeah.
Well, we can have an early morning tea, Boyd, if you like.
I haven't finished my I just like to pick you up on one thing, and you've said it a couple of times, and that's about this idea of kind of one size fits all. And I know what that means, especially around delivery of services. But within public health, there are a lot of policies which are actually one size fits all. For example, sugary drinks tax or banning junk food marketing to kids. That's non-discriminatory, it just goes across the whole population, or having all of the schools having healthy food policies or something like that.
Good point.
That can be actually very pro-equity, but it's a blanket policy, if you like. Some others that are a bit dependent on your resources or your education level, particularly public education, things can be not so pro-equity. But I just like to put a bit of nuance in this one-size-fits-all idea.
Yeah, good point. And I think there are elements in public health that are important, that are universal, but also in terms of funding or delivery of services, universalism doesn't always work, and we need to prioritise, coming back to the fixed resource or budgets that we have. So, for example, do we have universal oral health? This is a debate. There's no right or wrong answer. Or actually, do we, or for those who can afford oral health, I think I can pay for it myself. Do we actually prioritise funding and for those who have less means of paying? So I'm not saying there's a right answer here, but I'm just saying universalism can cost a lot of money if it comes to the likes of services. And so it's really how we can also target resources to those most in need is another means to think about. I'll just share one example of universalism. So in Massachusetts, where Boston is, it was a lot of public health approaches. Drive next door to the next state, which was New Hampshire. Don't even have to wear a seatbelt.
Really?
The motto was live free or die as you drive into the state. So I think there are fundamental forms of public health regulation that needs to be in place, I believe. But I just share with you a memory and an example. So drive next door, no seatbelts, less gun control, no tax on sales, including alcohol.
So this is live free and die.
Yeah, but public health mandates like masking, you know, those are all important public health measures. So you're right, Boyd, to think about some universal approaches that are needed in public health that can benefit everybody, and particularly Māori as well, that can also be thought about where the debate about universalism versus targeted approaches, particularly at a more of a service level, is a good debate as well.
We've just had that with the free school lunches as well. You know, they would really like, I'm sure, to target that, give kids lunches at school, but only to those kids who have food insecurity at home. But we do know that the universalism of it as it is applied
could be more efficient too.
Is way more efficient. It reduces poverty stigma, and also, actually, it's not just the kids that have food insecurity at home that are benefiting from school lunches. You know, 5% of the kids in this country meet the dietary guidelines for vegetable intake. We've got a third of the kids with overweight and obesity, and that's not just in the poorer sections of community or those that have food insecurity. So this question about targeted versus universalism, you've actually got to dive under the surface and really look at what all of the consequences are, because it's not a simple answer.
That's right.
Anyway, listen, Matarori, this has been a stunning session. I really enjoyed hearing your story and all of the various things that you've been involved with. I think you gave these students a great picture of public health, the diversity, the potential for impact, but also you brought in a bit of real politic of the changes and the struggles. Don't ever think that health and medicine is not political. It is fundamentally political, and the funding and the policies that flow down affect our health systems deeply, and you've been right at the leadership on that, and for that I really applaud you and really look forward to how we're going to move forward in Māori health in particular and public health. Kia ora.
Kia ora. Ngā mihi. Kia ora koutou.
Okay, folks, we'll see you back here in half an hour, 2 o'clock for the next session.
no, that's it.
Oh, there.
If you just log in there, maybe.
You got it.
Sign in.
Join a meeting.
Sign in.
Sign in.
Sign in.
Okay, now what? Oh, who was that? Oh, that was you. Okay. Well, she got your attention, didn't she? Okay, folks, listen, apologies. We're a bit late getting underway. Dr. Rawiri Jensen just realised this was in person and not online. So we've just had to create a Zoom link for him. So we'll put him last in the list, and hopefully if he logs onto this, he can just listen in, right? Yep. Okay. Well, I hope that's going to work. And in the meantime, we need to get underway because we're running a bit behind schedule. So that was a fantastic session this morning from Mataroria, really inspiring, and you're about to be inspired again by three amazing people who, they're not schizophrenic, but they do walk between these two different worlds of population health and personal health, individual care. And so you're going to hear their stories and their perspective. So I'm not going to give you any more on that, but because we need to get underway. So I'm going to invite Sam Menezes. Sam Menezes. I've got to write that, Sam? Okay, and Sam's going to introduce Dr. Almaya Herman. So over to you, Sam.
So we're now going to hear from the incredible Dr. Herman. So Dr. Herman is a public health physician and a general practitioner. She was born in the Cook Islands, and at the age of 11 years old, she knew that she absolutely wanted to be a doctor. And she now has a Bachelor of Medicine and Surgery, a postgrad diploma in ONG, a Masters of Public Health, and a PhD in Epidemiology. Throughout her career, she's been a strong advocate for Pacific people's health in Aotearoa and in the Cook Islands. To name a few, in 2018, she was leading the Auckland Regional Public Health Service through the Auckland mumps outbreak as a medical officer of health. In 2019, she was leading the Pacific Heads of Health through the Cook Islands dengue fever outbreak as their vice chair. And in 2020, she was helping with the Cook Islands emergency response to the COVID-19 pandemic as the Secretary of Health for the Ministry of Health Cook Islands. She's won the very prestigious Pacifica Medical Association Service Award in 2018 for her outstanding service to the health and wellbeing of Pacific peoples. And now she is the chair of E2 Pacifica Auckland, which is a primary care whānau order service delivered by Pacific Health professionals. And she's also the director of Pacific Health at Waitemata DHB. So she's a very, very impressive woman, and we're very lucky to have her here today to share some of her wisdom. Thank you for being here with us, and let's all give her a very warm welcome. I need a bit of help here. I just speak from here? I'll speak from here?
Oh, yes, over. Sorry. If you can stay behind here and just have that, yeah.
Yeah. Which one is?
Is that you?
Yes, that's me.
Okay, go.
I'll just put that up there. Kia ora ana tātou katoa. It's lovely to be here this morning, and like we were saying, having some discussions earlier on after Dr. Linden's presentation, it's all downhill now. How do you come in after such an excellent presentation? But it's just lovely to be with everyone here today, just on a cold Auckland autumn-winter season. But anyway, we'll get going because time's running out. I'm currently at the Ministry of Health now since February this year as the Chief Clinical Advisor for Pacific Health. There we are. And I suppose the story I wanted to bring in terms of movement between clinical, population, public health, etc., really centers on the Pacific region. I was born in the Cook Islands, and I did my undergraduate medical studies in Fiji. We had the coup in Fiji, and then I went to Papua New Guinea, the University of Papua New Guinea, where I graduated with my medical degree. And coming back to the Cook Islands, that's when I sort of started doing all the other postgraduate studies and work, which really has been between Auckland and New Zealand and the Cook Islands. So the Cook Islands is part of the realm of New Zealand. So we're New Zealand citizens, as is Niue and Tokelau. So really, I come really ready, done my medical degree, yay. All of us will be thinking about this. All your families will be saying, what would you like to specialize in? Which one makes more money? And for me, and least work. And for me, I wanted to do medicine, general medicine, because I really loved the art of understanding why people had hypertension and so forth. But I got back home to the Cook Islands and they said to me, you need to do ONG because we don't have a doctor that's female. And I thought, oh my goodness. What got me into it though was that it had a bit of medicine, it had a bit of surgery, and I thought, okay, best of both worlds, let's do ONG. So I came to New Zealand to do my diploma, and for the short period of time that I was doing ONG in the Cook Islands as well as here, I came to understand that when you start looking at a quality improvement aspect in health, you start thinking, hang on, these teenage pregnancies, could we have prevented them? And I always had this thing at the back of my mind, you know, we could have saved money if we had done this and this and this before the patient presented before us. And I suppose just coming back, I think times have really changed since then, and it just reflects how old I am, I think, in that when I did medical studies, public health wasn't sexy at all. And it was second, it was last, and next was primary care, being a GP. And look where I've landed now. I've done both of them without realizing what would happen. And I wanted to be a physician in the hospital. And so after doing my stint in ONG, and then sometimes I think I saw the light, I thought, I'm going to do public health because I think there's going to be more bang for my buck. I'll be more happier if I can focus on an area that stops people getting sick. And there were a lot of experiences I went through to sort of make me go into that space. So I did my master's and completed the Australasian Faculty of Public Health Medicine Fellowship. And then part of that as well, that was here in New Zealand. And then someone decided to, wasn't really decided to, but I was offered a PhD. And who wouldn't put their hand up for a PhD? This was with Professor Rod Jackson, Professor Shanti Amiritunga. Many of you might know these two colleagues. And it was around a special project that was being done in the Pacific region around road traffic injuries and injuries. And so I did my PhD. And mind you, while I'm doing my PhD, I'm doing this other work as well, because one job is not enough for me. But what it really taught me was the importance of having some skills that many of you already have at a much younger period of your medical careers in terms of epidemiology, understanding why diseases occur in certain populations, how we look at the preventative arm, and how money is put together in a health system so that some places get more money than others when you think, maybe we could have done better. So, and then, so I had been doing public health for quite a while, but you know, that itch, just to have that clinical bit, and I thought, no, I don't want to do long days and long nights and weekend calls at the hospital. Maybe I'll do general practice, and that's where I landed. So I've done my fellowship in GP. I do weekend sessions if I'm free, if I'm available, and it all depends on how things go. So I do my public health management and GP as well. Oh, I forgot to bring the bouncing thing. As you can see, I'm still learning these new things. So where have I worked? And I think this is the thing about it, that for us, when you're young, it's like, oh gosh, back in the day, you did one job until you died. Now, you do many, many different jobs. Well, the opportunity is there for you to go pretty much anywhere in the world. But I must say New Zealand's the best. That's my experience in the region. So one of my big jobs was really being the director of public health. This was after my fellowship in the Cooks. Now, the thing about this is working in less resource countries. Some of you might have gone to the Cook Islands, population 15,000, 3.5-hour flight from here, lots of flights every day now. When I went into the Cook Islands, it really escalated my exposure to other stuff that happens in the region, not just looking after a country and understanding health protection, health promotion, policy work, implementation, outbreak management, dinghy, etc., but also the regional work with WHO, SPC, which is the Secretariat of the Pacific Community, and learning about other countries in the region. And, you know, some of us over here might be quite competitive. For me, Cooks is going to be the best. And worked really hard to do that. But also even going to the World Health Assembly meetings, and I think it's on this week or this week, and understanding how policy is done at these global forums. Now, in the region, you saw that earlier map. That's the Western Pacific region, which New Zealand belongs to, as well as the Pacific Island countries and some of the Asian countries, China, Mongolia, etc., and Japan, Korea. So going into these forums, it was really interesting and a real learning experience for me in terms of understanding the mechanisms of the health system across the world. Coming back from that role, I actually went to Australia. You know, it was like I didn't do my OE, so I'm doing my OE now. And I worked in the Department of Health and Aged Care, which is our equivalent Ministry of Health in Aboriginal and Torres Strait Islander health. You know, family, that's the thing. Things happen. And after 1 year, you know, there were family commitments. We moved back. And it was a 2-year contract. But what I learned in Australia, and I always hold here, especially coming from the Cook Islands, is that Australia has lots more resources to work with. Over here, we fuss about giving out a $1 million project grant. Over there, maybe 5 million, someone might fuss about it. And, you know, I started understanding the inequities. In the Cooks, we hold on to $1,000, for example. So it's just understanding across health systems how resources are divvied out, how much you have access to. The other thing, of course, is that when I went to the Cooks, we were starting some reforms, went to Australia, and we were just going into reforms. And I thought, no, because a lot of change comes. And when you have a lot of change, it's a bit hard to sort of get things off the ground because there's a lot of uncertainty and so forth. Anyway, finished that role and then came back to Auckland, and I took up the role of Medical Officer of Health at the Auckland Public Health Service. I was the portfolio lead for measles, mumps, rubella, and we went straight into the mumps outbreak. So this was quite an interesting time in terms of trying to figure out how we would manage the disease. I had a background in epidemiology. I had a fair idea about what we should be thinking about for prevention. I must say that when it came to mumps, we picked up a lot of young Pacific, especially because Pacific carried the burden of disease, a lot of young teenage and young kids who were not vaccinated with our MMR vaccine. At that time in 2017, we thought and we were thinking about the fact that, hang on, if they don't have the MMR vaccine, it's not just mumps, it's also measles. So just to fast track and forward, we had the 2019 measles outbreak, which was one of the biggest that this country has seen. And unfortunately, maybe if we had run our vaccination campaign for MMR, we could have prevented a lot of that cost on health and the health system that happened in 2019. There was also an interesting time during this time when I was in the Cooks, and we had a typhoid outbreak. It was within a certain small Pacific community, and it was interesting for me to see it coming into a mainstream organization. One of the things that's important to understand is the importance of understanding the community you work with, the cultural variances, the diversity of communities, and understanding who the leaders are, etc. And I suppose on reflection, it's always easy to sort of think, okay, we could have done this better. But this case did not reflect well on our health system here in terms of the way we managed the risk around it and managed the communications with the family. You know what happens when people are not trusting the system, they shut down, and then the outbreak just gets worse. And we saw that in COVID again in some parts. So it's just one of those things that we need to think about as clinicians, whether we're in the hospital setting or outside. And then, of course, my GP work. So I suppose I could say the work I did in the Cook Islands was probably one of the most rewarding, intense, I didn't have a life. I did sleep. And I slept very well. That's a very good indicator that I worked really hard during the day, went to sleep at night, woke up in the morning, yay, I'm ready for work. But the responsibility was huge. And the thing is, we were going through health reforms again. So here we go again, restructure, and so forth. And the workforce was 300, and it was interesting to understand the dynamics, managing teams, looking for clinical leadership. Who are your main actors, in groups, in professional groups especially, and really around allied health, because the focus is always on the doctors, of course, then the nurses, and if we're lucky, we'll do allied health, where in fact we should be doing a lot more in allied health. And so I purposely put quite a bit of attention on the nurses and allied health to try and bring that workforce and lift it. We were also going through Public Health Act reforms, and I understand it's going through Parliament this year. One of the things we were doing with our Public Health Act was modernizing it. If you look across the world, even our Public Health Act is 1956, is it still? Gosh, that number still rings a bell. But the thing is, our Public Health Acts from the past, they're quite old, and they don't necessarily reflect modern public health, all the new things we have to deal with now, pandemics, etc. And it was an interesting time because in the Public Health Acts across the world, there's hardly any act that refers to health promotion. And yet health promotion is such an important aspect of our work, not just in public health, but across in population health. And so our Cook Islands Act has incorporated that. I think the state of Adelaide is the other one that has it in our region. Then, of course, 2020 came and we went straight into COVID-19. And that was a very difficult time. But one of the biggest things I take from this has been the ability for us to mobilize our community. You needed the community to sort of listen to the community and also have that relationship of trust where we could say, look, this is a big threat, it's existential, and the threat impact on our country, if it got in, is so-and-so, so-and-so. And fortunately for us, as a smaller country, we were able to shut our borders. And because New Zealand had shut borders here in New Zealand, we had double protection. And so there's always a link for the Cook Islands response to COVID to the New Zealand Ministry of Health or country response in terms of double protecting the Cook Islands. So interesting times, hard to think about. We were just talking with Dr. Jin about, gosh, who would have thought we would have been closing borders and shutting down boats? And I refer to a story where we had 2 cruise ships coming into the Cooks at the time when COVID was raging outside the rest of the region. And I must say, we were watching what was happening in Taiwan, what was happening in Singapore, in the Asian countries that were sort of sharing stuff. I became a friend of Twitter because we had to, you had to find information because you're pretty much, you know, the only public health specialist in the country. You're running the health system. You needed to think, I needed to think about how I could get information to help inform our government and our response. And there were 2 cruise ships still running at the time. One came and one of the islands, they did a whole anti-tourism thing, and they closed their borders and said no cruise ship is coming here. So the pressure was back on me. The tourist operators, they want their money. They understand, yeah, there's a pandemic or there's an epidemic, but we still want our money, or we want to do our work. In the end, just doing basic epidemiology. This boat had come all the way from Germany, I think, somewhere. It had been at sea for 4 weeks. It's like, okay, they left Germany before the outbreak had happened. And so there's a good chance, if there's no cases and the doctors on that cruise ship are transparent, there's a good chance that there's no one with COVID on it. And so we let the boat come in. 2 weeks later, another boat was coming in from Sydney. And at that time, we were getting intelligence from Sydney. And one of the things was that people had flown in from another place and gotten onto the boat. And where they were coming from, I think it was Italy, where they were coming from had raging COVID. And so the boat's coming our way, and we're saying, just wait, we're just getting more information, da-da-da-da. And in the end, I said, no, we can't. And so the advice to the government was, no, we can't take this boat. This boat became, it was in the news, had to go back to Australia and I think the western side of Australia, where they had a whole lot of COVID. And I sometimes think about this, perhaps some will think, oh, what a clever person, but in fact this was just public health, common sense, which I think public health is, population health. So some of the interesting decisions you had to make, I had to make, and for us, for you guys coming through your medical, clinical careers, you're going to be in these positions, and you need to rely on information that you can get from your colleagues, from publications, and sometimes it's just common sense, gut instincts. So in terms of, like I referred to before, the regional work, this was probably the part that was really exciting, working with MFAT, that's our Ministry of Foreign Affairs and Trade, the Australians are DFAT, and then UNICEF. It was really interesting hearing and talking to many of these representatives and to understand the work that happens at quite a large scale and how that influences what we do in the Pacific and in the Cook Islands. Another thing I was part of as well in 2019, prior to COVID arriving, and which was really, and I've put it here on purpose, which was really important, was really our ability to work with the New Zealand government, and this was Dr. Ashley Bloomfield and MFAT, and some of the Polynesian countries in the Pacific. We put together this dialogue, we call it the dialogue, in 2019. And when 2020 came in, we already had the mechanism to communicate with New Zealand, to seek advice, to seek support, and also to connect with the other countries. And so I've just come from Waitemata. I was there after I finished work with the Cook Islands. COVID takes a lot out of you, and I think I've only recovered maybe the last 2 years or 3 years. I took on the role of Director Pacific Health of a small team and looking at how we could improve our support for the health system in Waitemata. And this was an interesting piece of work. But when I first joined Waitemata, we were going through the COVID vaccination rollout, and we needed to set up our clinical governance for the vaccination program with the Northern Regional Health Coordinating Centre in Auckland here. So I went to give a hand to that process, and it was really interesting, really good in terms of bringing together primary care, hospital care, vaccination experts, immunologists, cultural, Pacific, Māori leaders into a space so that we could do right by the vaccination program. As you know, we had the anti-vaxxers, and for us it was important that we did this right. We needed to get it right by the people and really by our health system as well. And after that, then I moved back to Waitemata to finish off my work. So now, since February, I've started work at the Ministry of Health as the Chief Clinical Advisor. And I suppose, yes, can't do one job at a time and stay in one place, but I just find the challenges, really enjoyable. It does do a bit of, take a bit of stress on the body, but it's one of those things, if you know that you can do some work somewhere and there's a gap there, you take it up. But lots of opportunities, I must say, for the health career. And so, we come back to where we are today, so what? Why is population health important? And I suppose I just have a few bits here. And I was listening to Dr. Linden's presentation, and I thought, okay, I should just go home because he's just spoken about it. But in one slide, we need to remember health systems are expensive. The question is, are they? If you can have a health system run in the Cook Islands on a measly budget compared to the New Zealand one, where are we wasting money? Where are the inefficiencies? Many of you will be working in the hospital systems. Think about what we do with all the equipment that we use, our time, our resources, the swabs we use. Are we saving? And I suppose infection prevention control is so important because you don't want to get infections within the hospital settings. But it's one of those things about resources. But the key one for me, and it stood out for me from, over time, the importance of clinical leadership and governance. It makes your work easier if you're working with people that know the clinical aspects and to have some governance as well. You need a workforce to do the job with you. You need some money and also the ability to prioritize, to put things into the best places possible. We have a legislative framework. We all work within this, and we have regulations that help us with our daily work. You need some hospitals, you need some clinics to sit in, and the technologies that really make our work easier. Back in the day, we didn't have electronic patient information management systems. Nowadays, we take it for granted. Just remember, there's many countries not far from New Zealand that still work on paper. And so you can understand the quality improvement issues that they, would have to work with. And the community, don't forget to speak to the people that matter. Too often, we're busy trying to build our health system to serve the people, but we've forgotten to speak to the people. So if we think about the Māori boards, partnership boards, that's the best mechanism that you can think of to get closer to the people and listen to their thoughts, because many of our leaders, and as we found in the COVID response in the Cook Islands, the reason we did so well in the Cooks was because we brought on board the community leaders, and they pretty much already know or knew what we needed to do. And you didn't have to really work that hard once you explained everything. The other thing, of course, is that sometimes we are quite hospital-centric. We spend millions of dollars on our hospital systems, and that's important. When our 85-year-old grandmother falls over and breaks her hip, she needs orthopedic care urgently to save her life, prolong her life. But the thing about this is that we know it, primary care, public health has been underfunded for so long, and we make do with a small amount of money, but imagine if we could have a bit more, and it's not even a lot to ask, just to help do the preventative arm. Then, of course, New Zealand health reforms. We're working in that environment now, and I suppose this is a good opportunity, as much as it is not so easy to work through. The last health reform for the New Zealand was about 20 years ago when we went into the 21 district health boards. We are probably one of the most highly reformed health systems in the world. We've had 5 now in the last 40 years. Unbelievable. And the thing about this sometimes is also paying attention to what's happening around you in the global sense. I remember some of my colleagues last year sort of saying, jokingly, how many more health reforms are you guys going to have? Why are you still doing that? And I suppose it's one of those things. One, you could look on the other side that actually we're quite flexible in this health system, that the system is not working for Māori, it's not working for equity, let's fix it. You could look at it that way. But it's always in the process, how do you get to that end goal? And I suppose that would be one of the things where we push resources to the people, to the community, to primary care, to public health, population health. And then, of course, we've had this mentioned briefly this morning around what happens outside the health system. Don't forget about our determinants of health. The commercial determinants are really, really, really powerful when we have to work with big food, big tobacco, big oil, and you name it. These are very powerful sectors that Professor Boyd knows about, and they make our work really hard because you have a patient who comes in front of you and is addicted to smoking, and you think it's his fault, or when in fact he was exposed to tobacco smoking when he was much younger, and so the nicotine's really getting him going. And then we see vaping now, which is the next problem. Then there's, of course, the existential threats. Climate crisis, we can't forget about that. It's already impacting us in the physical environment, and we'll have much more to do in terms of impacting our future health systems and how we become resilient. The NCDs, the chronic diseases, we see it every day now. Gone are the days when you had 200 kilo patient turn up on your theatre table. Now many of you will see much bigger weights. And a lot of this then, it comes back to that environment that we live in right now, which is not healthy. This is a sick environment that we live in right now, and it's not easy for many families when they're limited in the ability to buy healthier foods. Then you look back at the taxation policies we have here. The Pacific Island countries are probably the leaders in this region, that we have sugar tax, tobacco taxes are high. And I know in the Cooks, I don't know if it's passed through Parliament yet, they're banning vaping bits. I don't even know what you call those, little gadgets, the disposable ones, and they're raising the smoking age to 21. Some of us might think, oh, maybe, this is a bit too much. People have a choice, but look what we're seeing in the hospital setting. So I think it's that balance of what's thing. And the last one I just wanted to talk about is antimicrobial resistance. We need to be careful because we're the ones prescribing antibiotics. Imagine this, in 10 years' time, we have a little cut on our arm and there's no antibiotics to fix it. And it gets into our bloodstream. So I think, in a nutshell, that's really all I wanted to say. And if it's been a crazy life, I think it has been, but it's just inspiring today to be here to talk to all of you, and we look forward to you joining the workforce. We desperately need you guys. And after Dr. Linden's presentation today, I said to Boyd, I can retire now because I think help's here now. Anyway, thank you very much for today. Kia ora ana e kia manuia.
Kia ora, thank you so much for that, Amar. That was fabulous, and boy, what a career trajectory you've had, and all the different options. Okay, just a bit of an update. So Dr. Jensen is on the line, and he'll present. But we will have Jin first, if that's okay. So I'm going to invite Rosie to come down and introduce Jin, please, and Rawiri, if you're listening, we'll have you online after this. Thanks. Kia ora, go Rosie.
Kia ora, everyone. It is my pleasure to introduce our next speaker, Dr. Jin Russell. Dr. Russell is a community and developmental paediatrician at Starship Children's Health. She has been the recipient of numerous research grants and clinical awards, including a Research Excellence Award from the Royal Australasian College of Physicians, a New Zealand Health Research Council Clinical Training Fellowship, and a 2020 Starship Foundation Fellowship. Dr. Russell has held several leadership roles within the Royal Australasian College of Physicians, having been a member or chair of more committees than I can possibly begin to list off today, and has recently completed a PhD in life course epidemiology, looking at how inequities in early childhood shape the developmental trajectories of tamariki. Dr. Russell has also been an invaluable public voice throughout the COVID-19 pandemic and beyond, lending her expertise, leadership and communication skills to promote safe vaccination and to continue to advocate for tamariki and their whānau. All of this at the same time as doing her other full-time job, being a mum to 2 young boys. Dr. Russell, thank you so much for being with us today. We really look forward to hearing what you have to share.
Kia ora koutou katoa, ko Jin Russell toku ingoa. No mangawhau te manga, no mission te awa, no tamaki ahau. Kia ora tātou katoa. Let me just turn this on. Dr. Elmea, that was an incredible address. It's hard to be in this lineup, you know. Really. The other thing is I want to say that I'm not so old that I've gotten used to people introducing me as a list of my achievements, just want to say that I am first and foremost a mama, and what that list of achievements masks is a lot of questions that I've asked along the way, a lot of uncertainty actually about my career. And the one thing that I want to communicate to you all is that it's possible to do population health or public health and be a clinician at the same time. Don't think that you have to do one thing. Don't think that you have to be in one job. Keep staying awake and keep looking. And when you're on the wards, talk to people and find out what they're doing and try and identify some of the things that make you feel really, really alive, things that you have energy for. I think that's the way now, in this sort of time that we live in, to build a really exciting career and to have energy. So I just want to encourage you. There's been a lot of questions that I've asked about what kind of contribution I can make to health for children that are masked by that linear bio, but thank you. When I did my paediatrician training, I worked at Starship and at Middlemore Hospital, and these hospitals are 17 kilometres apart. They're 20 minutes drive from each other. But what I noticed as a registrar was that the environments that children were growing up in were like night and day for some children. And that might sound quite naive, but if you can just understand that I'd grown up and my parents had, as migrants, come here for a better life and had specifically tried to shelter my brother and I from the poverty that they'd grown up in. So I grew up pretty sheltered and pretty privileged. And it was a real shock to me to see just how tricky things are for children growing up in disadvantaged neighbourhoods. I remember one night shift I was working on, a child who was 8 came in with a sore knee that turned out to be rheumatic fever, and his dad wheeled him into Middlemore ED in a supermarket trolley. There are lots of kids with asthma, but it's very different having asthma if you're living in a very nice home with 2 doting parents who have quite a bit of capacity versus having asthma in an overcrowded home, maybe English as your second language and so on. So I was very kind of moved by these experiences in my training, and I started to, after my shifts, started to come back home and do what a complete nerd does, and that is start to read papers. I think I was looking for answers in the scientific literature. This is one of the papers that I read which really moved me. It was done on the Dunedin cohort study. You might even know it. It's a paper that shows that children's self-control between the ages of 3 to 11 and the way that they can delay gratification for their own betterment is graded upon their family's socioeconomic status. And the really remarkable thing about this study was it showed that that level of self-control that a child has developed early on has ramifications for them at age 32 in terms of their health, their whether they might have addictions or not, how much money they have in the bank, whether their relationship is stable, or so on. And even things like their physical health, their obesity status. So what I came to understand from all my reading was that the early period of life in which children are developing capabilities, their cognition, their language, their socio-emotional behavioural skills, the things that me as a mum, what I really care about, these things are heavily shaped by children's early environments, and that the health system has a big role to play in this. And, in the health system, we like to count things. We like to count how many hospitalizations we see, respiratory hospitalizations, skin infections, and so on. But for families, I found that the things that often they cared the most about were the hardest things to measure. It's very difficult to measure. When your child has behaviour that is out of control, they can't control their impulses, and you're struggling to know, what do I do as a parent? Is it me? Is it the kid? Is it the school? What is it? And we struggle to measure these things, but I wanted to measure these things. I'm going to skip over this. So I signed up for a PhD. I got offered, maybe you're going to come away from this session thinking that you have to do a PhD after listening to. That would be the wrong conclusion, because I'm now working with a lot of people who do not have PhDs. But this, for me, as a paediatric registrar, wanting to get more involved in population health and have the skills that I felt were necessary to do this well, For me, this looked like doing a PhD, and I did this with growing up in New Zealand in the field of epidemiology. I'm just about to defend as well, which is this cartoon's very meaningful for me. Yeah, so my examiners don't know what's coming. This is just one graph from my PhD, which is a quiet graph, but I think it's quite alarming. And on this axis is the proportion of children in a neighbourhood, and in this axis is the level of deprivation of that neighbourhood. So 5 is the most deprived, and 1 is the least deprived. And I found a way to measure the things that parents really care about, that is their children's development and health together. And I worked out that if you took the lowest 10% on any one of those domains of development, like cognition and language, social-emotional behavioural, maybe your physical health, those domains, you could call the lowest 10% those children are sort of developmentally vulnerable. And here in the blue, the children who are developmentally vulnerable in one domain. As deprivation increases, you can see that we're getting up to sort of 1 in 5 children who are developmentally vulnerable on any of their domains of development. But the gradient for being developmentally vulnerable, sorry, this is at age 2 years. And then at age 4.5 years, you can see that it's kind of steepening. That the effects of deprivation are such that by age 4.5, just before kids go to school, that they might be developmentally vulnerable maybe about 1 in 4. And that means that those children are going into our public education system for the most part, and they're just behind. There might be a 2-year gap in their vocabulary and what they're able to understand and how they're able to hold thoughts in their mind and attend and learn. And that's going to have really significant impacts on their educational outcomes. And I just think, do you think our education system is alleviating these gaps, closing them, widening them, holding them steady, if we're lucky? I think the evidence would be that it's widening them. So it starts in early childhood. So I developed a portfolio career. This is a term someone put to me, and I like to talk about it now. I work 2 days a week as a consultant at Starship, and I see children in clinic as a developmental paediatrician, and I also see children in their community, so I do school clinics as well. And then for 50% of my week, I work as a community paediatrician within a population health team in Te Whatu Ora. Our team's called Population Health Gain. It's in this directorate called Service Innovation and Improvement. And it's a really interesting job. I'm with 20 other public health physicians, and I'm the only community paediatrician. So I feel lucky that they have me. But it turns out that having people who have a specific lens on children is really useful. There are also GPs who've retrained as public health physicians in our team. And I continue to do a little bit of research, and I had to figure out still, I'll be very honest with you, I had to figure out how to fit it in. And what I'm currently thinking is that you kind of rotate around different things in the way that Dr. Omiya just described. But what I'm finding is that having a balance of public health and population health work together with clinical work actually creates a really nice synergy. And I'll be in clinic, talking to families and discovering what the challenges are for them. For instance, we have a massive challenge in the country right now around autism and ADHD and other neurodiverse presentations, which is really important that we get supports in place. And there's a feeling that our health and education systems are not doing this particularly well. And I see that in clinic, and then I can bring those insights into the population health sphere, where part of the role of our team is to help advise decision makers across Te Whatu Ora and across the org, including people who are commissioning the community health services on the ground. So this is pretty important to have clinicians in these spaces doing that translation. I also do some volunteer work. So one of the roles that I had, interestingly, coming out of the pandemic in 2023 was, Tamaki Makaurau, we experienced a pandemic. We had longer lockdowns than other parts of the country. We also had flooding and displacement. And the mood was really low. And one of the roles that I was able to pick up with all these hats was to be an advisor to the Minister for Auckland over 2023, to advise central government on how to help Tamaki Makaurau children and young people recover. These are interesting roles that I think it's not possible to do if you're kind of stuck thinking about one particular thing. These are kind of broad strategic and very interesting roles. What do I do day to day? A big part of what I do is to bring population health frameworks into settings where they may not be talked about. And I won't go into this in a huge amount of detail, but just to give you that sense that what you learn this week, you can actually bring it into the environments that you're in. You can even bring the thinking into the ward round. So when you're, the frameworks that you're learning this week around social determinants of health, commercial determinants of health, and so on, or maybe you're learning about life course thinking, where investment in the early years pays dividends later in life. You can bring those kinds of questions and let your clinical experiences kind of foster that way of thinking, percolate for you. I get to work across all the layers, from the individual child, within schools, cross-sector in the community, right through to this population health role, where we might be, for instance, drafting a regional health and wellbeing plan or contributing to some health policy development. It's actually quite nice to work across all the layers of the health system. I quite like it all. I want to give you a specific example of some work that I did around the pandemic. In 2022, early 2020, if you can go back in your mind to that time without suffering too much PTSD, because we all lived through it. Most people were thinking about, when they said there's a virus coming out of Wuhan and it's coming here and we're going to need to shut our borders and we're going to go into a big lockdown and there's going to be baking and walks. Most people at that time, me, myself included, were thinking about how do we protect our elderly, because that's who the virus protects. And that was incredibly important. But as the pandemic went on and we were sort of in Tamaki Makaurau, we're flicking in and out of lockdowns, one of the questions that I was thinking about as a community paediatrician was, what are going to be the impacts of this sort of social experiment on children's development? How's it going to impact them? And the second thing was, how do we actually reopen our schools, our kindergartens and our daycare safely? How do we do that in a way that parents will trust? Because a big part of, I think, doing public health is actually getting people in the community to trust you. How do you get, if you've told parents stay at home for quite a long period of time, and then you want to flick and say, now we need you to send your children to school and we don't want you to miss any days of school, this is now the most important thing. That's a really hard kind of sort of shift for parents to do. And so I realised that there were not that many people in the country who were kind of thinking like this about children and young people and how the pandemic was going to affect them. And so I used the skills that I had and the positions that I was in to comment on and to end up advising on the COVID response for children and young people, to try and get the most balanced response that we could. This is a slide showing that, the number of well-child tamariki ora checks that a child receives, these are the universal health checks in the early years, received falls during the pandemic. There's an existing gap for Māori and Pacific children, and that gap is just maintained through this fall. So we have not only an inequitable response, but also a universal impact. But at the same time, we see, we have fewer checks, health checks, but at the same time, we've got greater number of calls relating to maternal mental health to Plunkett. And we know that there's been a lot of learning loss, and won't go into the slide in detail, but suffice to say that school closures disproportionately affect students from disadvantaged schools. It takes them longer to recover and they lose more learning. And I found that it was science communication became a really important role for me. That just like how we were hearing before from Dr. Almia, that speaking directly to the community was really, really important. And that explaining to the public why we could reopen schools, why it was important to do that, why it was important to get children to be immunised, particularly if they were vulnerable, why we needed health work to catch up on children's developmental impacts, why this was all important. And I was very busy for those 2 years, which is why it took me such a long time to complete my PhD. But there you go. And that work went on. So after that bout of sort of advising and policy writing and science communication, we actually went on to found a sort of pandemic impact steering group here in the Northern region to look specifically at how we can help catch up in the Northern region. And a lot of the thinking that happened in that steering group got then integrated into the region's health and wellbeing plans. And this is kind of one of the ways that I think population health thinking can feed into this big machine called Te Whatu Ora. It's through people bringing that thinking and doing that mahi and bridging it. One of the other pieces of work that I'm now doing with this epi and data background that I have is to build a child health intelligence dashboard for Te Whatu Ora to help advise commissioners and also lead clinicians, and also I hope other groups like our iwi Māori partnership boards. We want to gather data, good indicators of children's health, not just hospitalisations, but other indicators as well that speak to the experiences that children are really having, so that people can see trends in lifetime and see where the areas of need are so that we can invest better. So it's about sort of trying to be data smart. So yeah, in conclusion, I have this quite busy but really synergistic career, and I just want to encourage you that everybody can do population health if you want to. This is just one form that I've given you, but there's advocacy as well, which I hope Warui talks to. These are my boys. They're now 9 and 7. Thanks for having me. Kia ora.
Thanks so much for that, Jen. It's always incredibly impressive how much you fit into your life and have fitted into your life, and how you have done all those things. So thanks so much for bringing that to us and showing how it's not just a single job that you need to think about for your career. Okay, now we're going to cross to Rawiri. You can hear us, Rawiri? Yep, okay. So, Rawiri, I'm going to get you introduced for your presentation, and Osita is going to come and introduce you, and then we'll let you get on with it. We're running a bit behind time, as you might expect, so discussion might be a little bit short, but let's get on to your presentation. Thanks.
Kia ora everyone. Our next speaker is Dr. Rawiri Jansen. No Ngāti Ruakawa ia, Dr. Jansen attended Fairfield College and Hillcrest High School in Hamilton. Formerly a resource teacher of Māori language, Dr. Jansen completed his medical training at the University of Auckland in 2000. Dr. Jansen initially went to medical school in Otago. However, his studies were interrupted to be an activist and protester during a complex time in New Zealand's history, fighting for Māori land, Māori language, and a nuclear-free independent Pacific against the 1981 Springbok tour. Dr. Jansen works as a GP and is a strong advocate for improving health equity for Māori in his recent roles as the Chief Medical Officer for Te Akawhai Ora, the Clinical Director of the National Hauora Coalition, and as Clinical Director at the Papakura Marae. He is a strong driver for the revitalisation movement of Te Reo, working as the chairman of Te Atarangi Trust, as well as publishing a Māori medical phrasebook. His work to address the inequity and injustice which plagues our health system is inspirational and necessary for us as future doctors. We're very lucky to have him here today, so let's all give a warm welcome to Dr. Jansen.
So I'll do my sound check. Boyd, can you just, you're going to have to talk to me because I can't see you guys, but is that coming through all right?
Yeah, that's coming through, are we? Yeah, go for it. We don't have a camera on here. Well, let me see if I don't know if I can put a camera on, but it's only someone at the, there I am.
I can see you. You turn your laptop around.
I'll just turn that off, and I'll join that up when I come, and we'll do some discussion. Thanks, Rawi.
Okay, Edley. Yeah, so Yeah, Ngāti Henerangi, Ngāti Raukawa. So Ngāti Henerangi is interesting because we recently settled. So during that sort of COVID time, we settled our treaty claim with the government, in which the government apologised for attempting to exterminate our people, which is interesting because exterminate's now an issue in Parliament. I'm a GP and I love being a GP, and most recently I was the chief medical activist for Te Ako Whaiora, which since it got disestablished and they wanted to lift and shift everybody and shift them over into whatuora, I said, I'm not sure how much I can swear, but anyway, it started with F and it finished with off. And I'm most interested in an independent Māori health authority because it's consistent with our treaty claim. So I led the Te Ohu Ratu Aotearoa, the Māori Medical Practitioners Association, has been a significant contributor to the tribunal claim 2575, and part of the Stage 1 report recommended that there should be established a independent Māori health authority. Also the Health and Disability Services Review recommended that there should be a independent Māori health authority, with some internal disagreement about how much authority or budget it should have. But anyway, so we set up a Māori health authority. I went all in and gave it, full time. It turns out I was working for the Crown. I thought independent meant that I didn't have to be a Crown agent, but anyway, I had to sign the code of conduct and everything. That was a shock for me. But when they disestablished it, for me, that's a really significant moment in our history. So I guess one of the things for the population health kind of vibe is to notice that the environment that we work in includes that political environment, right? And it was lovely to hear Jin and Omea. So we kind of talk about community settings and then we talk about hospital and health system settings. And I think that's really important that we notice all of that complexity. I've got a slide to share on this matter. It's probably showing all my slides on the left, doesn't matter. The point is, this is from Williams and Van Dyke, and I guess every academic program will contest which is the best version of it, but everybody will basically agree that health outcomes are contributed to by these kind of different factors, right? And so clinical care at about 20% of the contribution towards health outcomes. It's really interesting, and I'm really committed to the idea that we have a clinical care system that does the very best job that we can for addressing inequities, for eliminating inequities, right? And then the rest of it, you see, reasonably, we have to be paying attention to the social economic factors and the physical environment, right? So the built environment makes a difference. So living in cold, damp houses means that many more of our kids end up with admissions to hospital and needing a paediatrician to support them. From my point of view, what it means is that population health requires all of us as clinicians to have professional opinions about poverty and about housing, that we have to speak up. We're obliged to. If we want to make a difference for our patients, yes, we have to do a fantastic job in our 20% of the system, but we also have to be absolutely clear about advocating outside of our 20% into the issues around education and employment and income and drugs and alcohol and access to legal aid. These things make a real difference to the outcomes for patients and whānau, and I think that's what we're obliged to address. The modified Williams model, and I guess if you guys are in Auckland, you may have been exposed to this. This slide tells me one thing: always, relentlessly, go upstream, right? And so as we go into those spaces upstream, we must be able to talk about racism and privilege and colonisation. So I'll just stop sharing that for a sec. I've got some different slides to interrogate you with. But for me, I think the kind of vibe that Jin was giving you, which says, actually, I really want all clinicians to be activists in the sense of understanding what are the factors that are impacting on this patient, on this whānau, on these disease processes, because that will be true, and I've been active in terms of acute rheumatic fever. And so Jin says, here's a guy who brings the kid in because the kid's got sore. Now, I had rheumatic fever when I was 4 years old, and the driving characteristic behind our rates of acute rheumatic fever is actually housing overcrowding, right? And rheumatic fever, it's not cold damp, except that cold damp means that more people are going to live and sleep together in the lounge than a cold damp bedroom if there's a broken window. So if we want to address acute rheumatic fever, then we have to talk about housing, overcrowding, broken windows. If we want to address, the asthma that our kids are being exposed to, and Māori kids are way more likely to end up in hospital because of asthma, then we do have to talk about cold and damp. So if we want to advocate for better health outcomes for the whānau and the communities that we serve, we actually have to be really engaged in advocating about housing quality, or the warrant of fitness for housing, or the requirements in terms of tenancy rights for patients. From my point of view, that is what we must do. I think it's reasonable to talk about equity, and I just want to remind you all that inequities are unfair, unjust, and remediable. That, the feature is that they can be fixed. So if it's unfixable, then it's not called an inequity, it's called something else. But there are a lot of people in our system who don't get this, right? There's a significant number of people who actually believe in equality, treat everybody the same. And I don't do that, and I don't want you to do that either. I don't treat old people the same way that I treat young people. I don't treat, people with a specific disease process the same way as I treat people who don't have that. I want to customise this response and this contribution that I can have working with a whānau that is according to their needs. In fact, I even go further clinically, and I say, a lot of people got this meme in their head that says, treat people how you'd like to be treated. And I say, fuck off. That's not the thing. How you want to be treated is because of who you are in this world and how you grew up and all of your cultural experiences and all of that. I get it. That's lovely. I want to treat you like how you want to be treated. And, so it's not about how I want to be treated. It is, how does my patient, how does this whānau want to be treated? And that's my job, is to wrap myself around what they need and what they want. And this healthcare team needs to centre the whānau. So whānau-centred care means that we have to do our job around the needs and the intentions and the preferences of this whānau. So put them first. And then just a few more. I prepared for a 1 hour session, Boyd. I can go on for ages. You'll want to interrupt me eventually. So in COVID, one of the things that we did badly was we delayed the vaccination program for Māori, and that was against the advice of the officials. I was on the immunisation implementation advisory group or whatever, and the government decided not to implement the advice which we had for them, which was Māori and Pacific needed to be prioritised in the rollout of the vaccine. And that didn't happen, and that is why Māori and Pacific had 2.4 times the mortality rate from COVID, right? So yes, New Zealand has this kind of world-leading, well, we did a really great job, and I think that's very true for Pākehā New Zealand. It's not so true for Māori and Pacific New Zealand. Actually, we had a very middling kind of COVID outcome for Māori and Pacific communities. We could have done better, we should have done better, and the COVID therapeutics was an example. So we did actually get ethnicity as an adjuster into that space. And so you can see in this graph, it's probably hard to see, depends how bloody big you've made me, but potentially you can see that Māori and Pacific accessing the COVID therapeutics at a younger age. That was really important. This one tells you in one slide why we have to change the bowel screening age. So if you do bowel screening for Māori at age 60, you're missing half of it. That is not a decent screening program if you're missing half of it. You know, for non-Māori, non-Pacific, you can get a fantastic program at age 60 and you are getting, you know, most of the bowel cancer. But for Māori, you're not. You have to do it appropriately. You know, battle's still going on, telling you that. It's been 8 years and counting. The ethnicity adjuster into the medicines for diabetes, this shows that it actually can be done and we get a fantastic outcome. Not perfect yet because Māori Pacific are not getting the total access to these medicines that we should, and that's partly because we've got a racist primary care system and access is a real issue. So we've got some work to do to make this where it should be, and we've also got to make sure that these medicines can be used for the other purposes that they should be. Anyway, I could go on, I would go on, but I guess my key point is that I think the contribution that public health and population health expertise makes to our system is absolutely critical, and I think that the contribution that you can make in our total system is within your specific operational day-to-day job, but it's also wider than that. So if you're a nurse and you're working with whānau, whether that's in cardiology or diabetes or whatever, I get it. I want you to do the very best job that you can in your clinic. If you're a manager, I want you to do the very best job that you can in the system that you're managing, and I want you to be able to talk about what happens outside of that part of the system that you work in. I want you to influence, I want you to advocate, because I'm interested in equity, getting the right amount of resources to the people who need it. So I'll take any questions.
Okay. All right, the activist recruiting session is now open. So if I can just ask Gina Naumea to come up here, and we'll give you... Oh yeah. Okay, there's one. Another one. Oh, you can share? Okay. All right. All right, we're just going to have, we've got 10 minutes for some questions, folks. So those people in the region, I should say Rawiri, that we're beaming through to Pukauakaua and Waikato and Bay of Plenty and Taranaki. So those students are online. Those students, if you want to put a question in the chat to any of these fantastic speakers, and we'll take any questions from this group here. And if you just shout them out, I can repeat the questions. So any questions that people have of particularly this idea of, I hope you've got a strong sense of this interaction between clinical and public health, and the way that these amazing people have been able to go backwards and forwards and join them both. I'm sure it was quite difficult for Rawiri, having spent all this time attacking the system, to be someone from the inside. So it'd be interesting to hear how his view is about change. If we've got change at our heart and we want to make a difference, the challenges from the inside and the challenges from the outside. So maybe Rawiri, if you could just kick off on that one, that might give us a little bit of insight. Thanks.
Well, I guess one of the things I was really interested in doing is breaking through in terms of that equity meme, right? So, you know, getting the right amount of resources for the problem that we're facing. And in Te Aka Whaiora, we did that. There was a fund of some $23 million or something to support primary care, and it came out in the final stages of the last government. And so we had a battle inside the system about what to do with that money. And some people were advocating shamelessly that it should just go out to, you know, $10 extra or $15 extra for every Māori Pacific patient. And so I don't think you solve inequity by doing an equality response. And so I was advocating that we've got evidence that actually the additional funding that you need to be able to do a good job of looking after Māori and Pacific patients is about $220 per year. And so the 22 million, if we did it that way, and that's what I started off advocating, I had to swallow a dead rat later on, but I was advocating that we actually demonstrate that we can do it. It's for a small part of the population, but we go to some providers and say, you've got this amount of Māori Pacific patients, we'll give you an extra $220 per patient per year, and you do great work. And so it was a very simple contract, Boyd. It only had 3 parts. We give you the money, you do good work, but we get the data. It's absolutely essential that we have primary care data available into our population health and public health systems, and at the moment we've still got a legacy belief amongst GPs that they own the data. They do not. We have to break that. But anyway, so I was trying to do this pro-equity way of getting the funding. I didn't get the 220. What I did get though was, if you're a Māori and Pacific provider, you got $80 per patient per year. If you're a non-Māori, non-Pacific provider, but you've got 50% or more Māori and Pacific patients, you got $40 per Māori Pacific patient, and all the other practices got nothing. Some people got no box, some people got 1 box, and some providers got 2 boxes. We established that as a principle. Then we got disestablished. But I'm just saying, you know, like I had to swallow a dead rat because I had the perfect funding model, couldn't get perfect, but I wanted to get to a place that we said, actually, let's have a funding model that does address the resourcing that is relevant to address inequity.
Thanks for that, and I just wonder whether Jen and Omea have a view, because you've been shifting from inside to outside, and particularly with the health communications that you talked about. You're trying to create those stories which will influence the system, and then you're part of the system and trying to operate from the inside.
Yeah, I experienced a similar shift from doing a lot of the COVID work that I did as a friendly critic, is how I describe the work that I did. Friendly critic to the government, friendly critic to the official public response, but then it turned out that my style of communication was calming for people to the extent that I was asked to front the official campaigns. And that was a shift that I did because I thought it was necessary. The shift then being offered a public health job, so coming further into Te Whatu Ora and being in the system. So it's hard to sort of shake your fist and say, Te Whatu Ora should be doing this and Te Whatu Ora should be doing that, when I am part of Te Whatu Ora now. What I'm finding though is that I'm learning different ways of making an influence and influencing. So there are different ways, there's different types, and it might be that you have to find a style that fits you and the job that you're in. There's the critic, there's sort of an advocate on the outside, but then when you're on the inside and you're privileged enough to work at this level, then you need to actually work within and embed thinking and shift the dial inside the system. So that's what I'm learning, that's my reflection.
I think Rawiri's just pretty much said what needs to be said. In the Cooks, where I pretty much controlled the budget, we were able to lift that budget to a much higher number. We're just talking $1 million compared to what we have here. But it was really about having the ability to understand what the system needed to improve things. And I come back again, clinicians don't have all the answers, but sometimes we know quite a bit about what might work for our people, and if we have a strong understanding of the community, the pain that our community go through, the needs that they are asking for, then it makes it a bit easier. Not easy, makes it a bit more, what's the word? You have more information to inform the process that you might want. But definitely if you run the system, then of course you have a better chance of putting the money where it's supposed to be. So the disestablishment of Te Aka Whaiora is not a good thing for Māori. But I know there are many colleagues out in the health system that understand that process and will be finding other ways. There's many ways to get the same outcome in terms of financial means or funding and so forth, and there's other ways, but it's the harder way perhaps And I suppose Health New Zealand we could do this much better, I think, when we see some of the other countries in the world in the Pacific that use lesser resources to do the same thing. But I must say that for the amount of money that we have in this country and what we deliver in hospital settings is great. Primary care, we have a big job to do. And having people like Rawiri in the primary care sector and advocating is really important. Thank you.
Thanks for that. We've got a question from someone from the regions. Yeah.
Yep, Joseph Firth, I'm not sure which region he's in, has said, thank you for your inspiring talks, for all three of you. His question is, how do you continue to find the fire to push for population health perspectives and lenses when clinicians in multiple sectors feel too burnt out to care?
Wow, that's a great question. And Alme, you talked about the burden of health reforms and the chaos and the challenge that is, and that we went through all those in the 90s, and now we're going through it again. So maybe I'll start with you about the sort of the challenge of the burnout when people are just feeling over reformed or overworked.
Yeah. I don't know. It's individualized. It's, some of us can bounce back, others need time. My thoughts are, when you're younger, you have more energy and you're more flexible and pliable. When we get older, then it's not such the same. The other thing is, when you've got family as well, you've got other commitments that you have to also take note of. But I do think that when we remember that we are working in a health system as a team and not as an individual, and that it's okay to share the load, then things can become much more easier when we break it down. And I always remember this saying, the health system will continue when you're dead. Don't ever think you're not indispensable. And I think that's the big one. Sometimes when life gets really rough and heavy, and you think, well, if I wasn't here tomorrow, if I wasn't the Secretary of Health tomorrow, it will continue. It might not be the way I would want it to run, but it will continue. And the job for us, if we are really passionate about a particular part of our role, is to find ways to influence that particular sector. It might be a new Secretary of Health, and so you find a way to influence them so that they keep on the path that you are hoping would be the best for the people you serve. So that's really my insight into that. Thanks.
Thanks. I wonder if you just pass to Jin as well. And this, it may be, Jin, that this burden and this burnout does fall particularly heavily on women, and you put yourself up as a mama first, the head of, paediatrician and public health expert and things. And so when the going does get tough, the burden does seem to fall a bit disproportionately to women.
Yes, it does. Although I married a feminist, that helps. I'm not just saying that. My husband literally teaches feminist philosophy on campus as part of his job. Yes, it can be difficult to do the juggle, and I actually just had an interview with, I've just had a podcast episode go up a couple of days ago on Petra Begas' podcast, which probably none of you listen to because her audience that she's aiming for is sort of 50 and above, but we did a whole hour on failure.
Did you?
And achievement and what that feels like. And you are all extremely successful people to be in this room. You're all just so full of potential. What you need to know is that people just like you who are caring and successful are at high risk of burnout. And so there's a way to do this career, there's a way to do it which doesn't leave you feeling burnt out, and it will be different for each of you. So I've just got three pieces of quick advice. One is find mentors as you go through, and it's okay if they're just short term. Just find people that you click with who are a little bit further along and can top you up. The second is do what brings you joy outside of work as well, and look for the things that you do in your jobs that bring you joy and hold on to those things, so go after those things. And the third thing is just what Almea was saying, we work in teams. we're a team of teams too. We work in teams, and you're not alone.
Thanks. I'll leave the last word to you on that, Rawiri, about burnout. And earlier this morning we had Mataroria Linden give the keynote presentation, and it was quite emotional actually about what was happening what has happened to Te Aka Whaiora, and after decades of sort of trying to build it up and then it gets squashed. So from the inside, you have any comments on that about how people cope with this pressure and this potential burnout?
I've got competing thoughts about it, Boyd. At one level, I don't really get into the burnout thing, and then I've got to tell the truth, I ended up in a bad place one time myself and needed to get some help and some support, and ended up going to community alcohol and drug service for about 3 years for stress management support and reduce my alcohol response to stress. So but I'm still in denial about the burnout thing, because fuck it, whatever the system gets changed to, we've still got this responsibility to do the best that we can, right? And so the thought that comes to my mind is that culture eats strategy for lunch. And I'm no expert on organisational design. I don't care what kind of organisation you get, and if you employ me, I'm going to be really driven about specific things. I want to do the job you give me, but I also want to interact with others. I want to make sure that we have interdisciplinary features of our system, right? Now that's culture, that ain't strategy. You can write a strategy that says everybody must be interdisciplinary. That's not going to help us. Culture eats strategy for lunch. It's on us to do a much better job of looking after each other. It's on us to work interdisciplinary so that we do a much better job of looking after whānau and community. So I don't know, I've got a complex response to the whole question, but anyway, it's on us, people.
All right, well, listen, thanks for that. And speaking of lunch, it's about that time. So we will just wrap this up. If you can just join me in thanking these three amazing people for their presentations. Okay, everyone, we're back at 1 o'clock online, and we'll talk to you then. All right, guys, come and take a seat. Okay, folks, welcome back. Sorry, it's a bit of a short lunch hour, lunch half hour. Anyway, we're going to now just go over what your week ahead is. And already we've had a bunch of curveballs thrown at us. So people in Pukawakawa who are listening, in case you haven't heard, there are 2 cases of COVID, COVID positive people from the accommodation up there, for which most students are in. So for those of you in Pukawakawa, we're just in the process of shifting your activities to online with Zoom links. So Caroline and Anna are working on that. So this afternoon's session with your facilitator, what's that? It'll be what? In person? Oh, okay. So, right. Okay, so let me just update that. People in Pukawakawa, for the sessions this afternoon, they will be both in person if you don't have COVID, and if you do have COVID, then you'll be online, and there'll be a link sent to you for that. For the following session tomorrow on population health and action, I think we're going to make that fully online, are we? Or we're going to do the same? Do the same, okay. So Pukawakawa, everyone is going to have to get tested, and we'll run a dual sort of activity. There are other individuals who have contracted COVID. Now, how we deal with that, it depends to a degree on how severe COVID is and how laid up the person is. And they'll need to work with the facilitator and with us on that. Just as a reminder, all of population health intensive is compulsory, including all of the sessions. So if people do miss out on various sessions or various parts of it because of illness, then we will sort out some remedial work to back that up. So for example, these sessions and the population health and action session and the presentations are all going to be videoed, and so the remedial work may just be reviewing those videos, or if they miss a lot of the teamwork, then there'll be a separate project we'll need to put up for them. So if people out there are zoomed in and they have tested positive for COVID, we need to work out with you individually how severe your disease is, and how severe your infection is, and how we're going to manage your week. There is also an apparent clash with path lab tests. So has anybody in the room got that clash? Yeah? Tell us about this. This is delays in autopsy viewing or something, is it? Because they didn't have enough bods in the cold room, no? So tell us, what's the story with the path labs?
The march is tomorrow, so at 2, so it's not clashing with any in-person activities. It's not clashing with anything either. Yeah.
So because we've got population health and action session tomorrow, which is compulsory, and you've got labs that are supposed to start at 10 o'clock, is that correct?
No, 2 p.m.
2 p.m. Ah, okay. Has anybody got 10 a.m. labs? Path labs? You have. How many of you in your group? You have as well. Okay, they've been delayed 3 times. Twice, okay. All right, we'll get a hold of whoever organises that. I don't know quite who the organiser is. Do you know? Who's that? Oh, Zoe. Okay. Right. Okay. Well, listen, we'll try and get to the bottom of that and see how we can arrange that. And so keep an eye on your emails. Those people that have got Path Lab sessions. Yep.
So if you haven't actually emailed us or let us know, can you do that so we can track who we need?
Yeah. If anybody has got a Path Lab session tomorrow at 10 that's going to clash, let us know. All right, those are the sort of emergency things that have appeared. Just before we get started, I just wanted to acknowledge New Zealand College of Public Health Medicine and MAS, the Medical Assurance Society. They are giving you a bit of money if you win the prizes on Friday. So they've chipped in a bit for us. The New Zealand College of Public Health Medicine is the New Zealand specialty group for public health medicine. There is also an Australasian group which is part of the College of Physicians, so people who are registered public health physicians can be registered either with the New Zealand College or the Australasian section of part of the Royal Australasian College of Physicians. MAS is some of you might belong to MAS. It's a medical assurance society started by doctors 100 years ago. The last several years, have established the MAS Foundation. I'm on the board of that, and it's this MAS Foundation is the sort of basis for what we're running your task for this week around pitching to them for $1 million. All right, so let's look at this week ahead. So we've just had those great presentations. Jesus, they were good. These are people, they're absolute stars, really, committed at all sorts of levels. And so I hope you got a lot out of that. I thought that was spectacular. So we're just going through this today. Then at 3 o'clock, you're meeting with your group facilitators to learn about your project. Tomorrow morning, from 9 till 10:30, we have Population Health in Action. That's where you get a little bit more of a sense of what the day job of public health physicians is all about. Tuesday, Wednesday, Thursday, you'll be meeting with agencies and research topic expert and developing your project presentations. And I just want to give you a sense of the size of the scope of this week that's been developed for you guys. This is massive. We've got 26 groups, and each group has 7 to 10 agencies that have been organised with appointments made for you to go and visit them and hear from them. We've got topic experts for each of them. We've got group facilitators. This is a massive enterprise to give you guys a solid population health intensive week. And Anna, I'd just like to pay tribute to Anna, who has been working on this, and she's been organising it also. It really is a huge exercise. At midday on Tuesday, Wednesday and Thursday, I run a Zoom session with one representative from each group. And we will, so that's where we put together questions and answers and so on. We've found that they have tended to run over 1 hour a bit. So this time we're sort of splitting it in two. It's probably going to be 12 to 13:30, is it? Yes. So 12 to 13:30. So it's yeah. So we'll tell you which slot you're in, the sort of the first slot or the second slot, just so that you can come in for your session and questions. You can obviously listen to the whole lot. It's actually quite instructive, listening to the struggles and the challenges and the questions that other groups have. So it's not a bad thing to listen in, but it's just try to make it a bit more efficient to give you a time slot within that. And then on Friday, you're presenting your strategy to one of 5 teams. So I'm just going to go through that in a bit more detail, starting with some expectations, some logistics. I've got Canvas up there. This is really a slot for Anna to tell me the bits that I have missed out on talking to you about, and any things that have happened in Canvas, but I'm assuming you're all pretty au fait with that. And then we're just going to go back around this concepts of thinking about population health, and Rawiri Jensen's final comment about culture eating strategy for lunch. This is about culture, this is about ways of thinking, this is about mental models. And so yes, you'll get into the nitty-gritty of what population health problems are and their solutions and actions, but at the bottom line is I want it to be able to influence your thinking. All right. Compulsory, I've just mentioned that. Anybody has any illnesses or absences for any reason, you need to let me and Anna know, both of us. Don't rely on me looking at my emails, you have to put Anna in as well. Teamwork. Now, I know you haven't necessarily done a heck of a lot in teams in your training so far, which is a bit astounding because you're going to spend the rest of your lives working in teams. And so you need to work in teams, you need to understand how teams operate, you need to understand the different values that different people bring to teams, and this will be a case for that. So diligent team membership and contribution is expected and assessed. So at the end of, on Thursday, you'll all be required to submit not only a group piece of paperwork just outlining your the agencies that you went to and outlining your project, but you'll also put in an individual one with just to show that you've been to at least 3 agency meetings and that you feel that the members of your team contributed equitably. So we don't want any slackers in teams, and if you are a slacker, then your teammates will pick you up, and we will check that out as we have done in the past, and you may need to do remedial work. Okay, so the teamwork is, because it can be totally destroying having a slack ass in the team, just dragging the chain, getting everyone else to do stuff. So that is assessed. Now, engaging with the problem that we're giving you. These problems are so tough that the experts in the world have not sorted them out yet. And we're giving you a week to get your head into these deeply complex problems and try to come up with a piece of a solution, some action that's going to make a difference. So grappling with the toughness, grappling with the complexity, grappling with how difficult it is to find solutions is all part of the learning process for this week. So you need to engage with that, and especially when you're meeting with agencies, these people are giving you their time. They are doing it voluntarily. They enjoy having medical students come. They enjoy telling you what they do. They're usually very passionate about it, and they want you to hear their story. And they have fabulous stories. They are big contributors to the health of our nation. And so, when you're with them, please treat them with courtesy and decentness, as I'm sure you are, and be attentive to them and what they do. Now, you might be meeting an agency and you're already forming your idea about what your campaign is, and it might be in another part. That doesn't matter. You just engage with those agencies and understand where they're coming from, what they do, and give them your full attention. So that's great. Not everybody is meeting every agency. You'll drop into groups, and there'll be 3 or 4 or whatever number goes along to these different meetings. You'll have to work that out, but each person needs to go to at least 3. So those are the main expectations for the week. So we're in 26 groups, 8 to 12 a group. You're given a topic, you're given a group, you don't have any choice. The assessment is a group assessment and it's pass-fail. And that's based on your work, what you hand in, and your presentation. On Friday, we have you in 5 streams. So we have the 5 in Waikato. We'll be presenting to each other in person. The rest will be online. The 2 from Pukawakawa, the 2 from Bay of Plenty, and the 2 from Taranaki will be joining each of the Auckland groups. There'll be one group which will have 6 in it, because 5 into 26 doesn't go, carry 1. So one group has 6 presentations and the rest have 5. And we choose one winner from each stream. So you have a facilitator whom you'll be meeting this afternoon at 3 o'clock. Many of them are from the School of Population Health, and this is this Population Health in Action is a major enterprise for our whole school. So just about our whole school is involved in teaching you and supporting you some way this week, either assessing or as experts or as facilitators. But there are other facilitators who are not part of the University of Auckland. They might be part of Public Health Service, or others who have working in population health. So they are contributing their time to you. Sometimes you might be a bit lucky, your facilitator might have expertise in the topic, but mostly they don't. They're there to help you with the group, to help you get organised, to help guide your campaign. They're there to bounce ideas off. They give feedback on your presentation, so we're expecting on Thursday that you would run a practice presentation and get critique back from your facilitator. You're meeting them on Monday, and at a time that you choose to present to them on Thursday, and then any time in between. If one person within a group can be the liaison with the group facilitator, that's good. So then that facilitator knows who to connect with, and they might just want to check in each day to see how you're going. The Zoom session that we have at midday helps to alleviate a little bit of that role with questions, but use your facilitators. All right, these are the topics. They're pretty tough. This one here, elder abuse, was on the front page of the Herald this morning, with elder abuse from, particularly from migrant populations, Asian, South Asian populations. They're saying that like 1 in 10 or 1 in 3 or something. There's a large number of elderly people are subject to elder abuse. It may not be something you've come across or even thought about, but it is big. And a lot of these other things are big challenges. These are the Auckland ones, and these are the ones around the regions. Some of them might be quite challenging for you. Child protection, intimate partner violence, alcohol misuse, illicit substance misuse, problem gambling. You may have personal experience or experiences within your whānau or people that you know in that area. Mental health is a big one. Rainbow health. It might be quite challenging for some students. So just be aware of that within your group and be empathetic towards that. If people are struggling a little bit with that, please talk to the facilitator about that. But these are difficult and tough issues. But they're challenging issues, and this is, as Rawiri Jensen showed, like about 80% of our health in this country, the determinants of our health, come from stuff outside the hospital system, outside the healthcare system. So this is, when you dive into these, you will find the societal causes of them, and that's what I really want you to get your head into. Okay. even though these are challenging issues, I have been blown away by the degree of sophistication of students in the past for grappling with these tough issues and for actually coming up with really insightful and thoughtful and innovative ideas. So these are tough, but you guys are smart and you're up to the job. Okay, so these agencies will be a group of people. I'm going to have to take DHBs out of it. There's no such thing as DHBs anymore, although the health services do still operate in regions. So there'll be NGOs, there'll be community organisations, public health units, schools, local government, those sorts of things, sometimes academics who are working in the area. The appointments have already been made with the agencies. But one of the first tasks that you need to do at 3 o'clock when you meet with your facilitator is to appoint someone or select someone within the group who is responsible for contacting agencies. They are expecting you to contact them this afternoon to confirm the meetings. Now, some of them need Zooms. Some of them still need Zooms, do they, Anna? Yeah. So some of these agency meetings will be face-to-face and some of them will be Zoom. So whoever is setting these up will need to use their Zoom account to set them up. Now you should all be hooked up with Zoom Pro. Yep. So you can do the full hour. You don't get, it doesn't chop you off at 45 minutes like the cheap version. So one of the first tasks you do with your group is to set up that person. That person, while you're talking and discussing the rest of the group activity, will be double checking with the agencies to confirm this and setting up the Zoom links. Got that? Okay. And keep an eye also on Canvas, because sometimes the agencies will come back and say, oh, this time's not good enough, can we change it and things. So do keep an eye on Canvas because those appointments might change. All right. When you meet with the agencies on Canvas, there is a list of questions that you can be talking to them about. You might have your own set of questions as well, but go in there and ask them sensible, intelligent, probing questions about their work. You're not just there to listen, you're there to ask and to understand their work. So, yeah, speaking up, asking questions like you did in the symposium today, that's good. They're giving their time for you, so show respect and thank them for that, as I'm sure you will. Okay, we've got sets of topic experts. Now, some of them are from our school, some of them are outside, some of them public health units, some of them from other universities. They're usually academics working in the population health area. We have one meeting set up for you with them, but you are at liberty to contact them again if they've got specific content questions about the project. So they're the go-to person for contact expertise. Now on Canvas, you will have people in your group who you allocate to the kind of research job, where they're diving into the research and they're diving into the papers and understanding what the context is, what the rest of the world's doing about this problem and so on. So there might be one or two of you, a couple of you with that job. Within Canvas, there are a set of some recommended readings. We've just been through them over this last year and updated them. There's probably about 20 or so website links, reports, academic papers of use, but you'll find also there are other papers or other references that you want to use. We get you to list those other references that you've used, because then that'll be good for the next lot of students coming along. So please make use of that list of papers and dive into that and give us some extra papers if you use them, if you think they're useful. All right. So this is pass-fail assessment, and your task is to build a compelling campaign, which I'll talk about in a minute, about how to improve some aspect of the societal conditions and all the systems related to the problem. So you could be looking at a cause or a driver, something that's driving it up. You could be looking at a barrier to action. You could be looking at a policy action which will improve the policy environment to be able to make decisions. There are lots of different strategies, and we'll come to some of those strategies. Most of these strategies will be completely foreign to you. They're completely different to what you have been learning in clinical medicine. But as you heard from people today, once you get into that population space, you need to have a whole nother set of skills and ways of thinking to deal with that population stuff. It was interesting listening to our mayor talking about WHO and all those, that kind of world. Because as she said this week, it must be this week in Geneva, all of the health ministers of the world gather and go through a whole lot of different processes, and that is a very eye-opening process, and that's how kind of global health and global health recommendations and things are all developed. It's highly political, and it's really an eye-opener. But as I said, health is political anyway, so it's probably not a surprise to you guys. Okay, we need some stuff submitted through Canvas, so we just have a short written report on your campaign. That's for the record and to show you've kind of gone through all of the bits, and that needs to be in on Friday, at the end of the day on Friday. You'll have the individual worksheets, which agencies you visited, your assessment about the workload equity and the workload distribution across your team. If we get people who think it was unequitable, we'll go back to the team and find out more about that. And we also get you to sign permissions. And that's because the presentations that you do on Friday will be videoed. The ones on Zoom will be captured on Zoom, and there'll be people taking videos down in Waikato. So we keep those videos. We send links to them back to the agencies. So if they haven't been able to attend your presentation, they can click on that and see what magical stuff you guys came up with. We send it to the topic experts and the facilitators so they can see what a wonderful job you've done. And then the winners of each stream, we use those as exemplars for next year's fifth year medical students. So on Canvas, you'll find the 5 stream winners from last year to get a sense of the level of quality of presentation and thought and everything that went into their presentation and their campaign. I don't want you to plagiarise their ideas, of course. So if alcohol misuse won and they had a particular strategy, we don't want to see that one come up again. There's plenty of scope within the whole alcohol field for you to have lots of different activities. So please do that. I should say also that some of these topics, I should have mentioned when we were looking at the topics, some of these are really broad, like climate change and transport and poverty and stuff, which makes it a big challenge on the one hand because you've got this vast area to choose from, but that's good because you've got lots of things to choose from. There are some which are a bit narrower. Rheumatic fever is quite narrow, but because that is such a major problem in this country, it's really a developing world problem that we have in what we think is a wealthy country here. So we do keep rheumatic fever in, even though it is relatively narrow. So sometimes these narrow ones, yes, you have fewer choices, which can be good or bad. Anyway, On Friday, we start the presentations. I think the first one starts at 10:30, is it, or 11? 10, maybe 11, is it? One starts at 11 and they all start 11:25, and then the other start at 11:25. Okay. So by that stage, you should have your slides done, and we'd like a PDF of those submitted on Friday morning as well. Then you got your presentation, 15 minutes presentation, 12 slides and questions, and there's one winner per stream. Now, distinction. I'd really like to encourage you, if you're interested, to apply for distinction. So there are two choices here, and we have 2 population health prizes. So you've got double the chance of winning than if you go for surgery or ONG or these other distinctions. And you can let your creative juices flow. I've been amazed how much creativity, artistic creativity, lives inside medical students. Let it come out. So we have a choice of a creative work or an academic piece that comes out of about 1,500 words. The creative work has some explanation around it if it requires some explanation. And those we give you a few weeks after the end of this week to put that together and email it to Anna. And that then we get 2 people to judge those, and some people will be awarded distinction from that group. So several of you will get distinction, and we'll have 2 prizes from it: the top in the creative work and the top in the academic essay. Now, the top in the academic essay, we work with the New Zealand Medical Students Journal. I'm sure you people are familiar with that. I think it's a great journal. I think people that are organising that have done a great job. So we like to submit, we'd like to get the winner to submit their winning entry to that Medical Students Journal for publication. You can put that on your CV. And I think they may still do creative pieces as well periodically within the Medical Students Journal. So anyway, nice to get excellent work published, so please think about that. All right, groups. So from 3 o'clock, you're going to need to get yourselves organised into roles, and there are lots of different roles. And this is the value of teamwork. Each of you will have different attributes and strengths and weaknesses and things you like doing and things you don't like doing. We need to get those on the table, and your facilitator will help you guide that. Think about group work that you've been involved with in the past, or organisations that you have been part of, or committees or something like that, and think, when I do that, what kind of a role do I take? Do I like to be the person that's behind the scenes doing all the organising and getting all the ducks lined up and making sure all the people are in the right place at the right time? There's plenty of organising jobs for those people. The timetabling, hooking up those Zooms, the agency visits, sorting out who's doing what. Chairing. So with any group process, you need a chair. And the chair is not the boss. The chair is the facilitator running the process, making sure everybody gets a fair say. So the role of the chair is running the process. Researching, as I said, diving into that, liaison with the facilitator, coming to the midday sessions, liaising with the topic expert, liaising with Anna if needed. Who likes writing up the reports? Note-taking. Who likes developing slides? I have to say, almost every single presentation I see from medical students has way better presentation style than I've ever done in my life. But not much of it's rubbing off. You see, it's pretty boring. Anyway, developing the slides and then presenting. Some people like presenting. Most people don't like presenting. I would really encourage you, to whatever opportunities you get, to stand up and practice your presentation skills. This is a really, really critical role, and people are quite fearful of it in general, and it's true, it's a bit nerve-wracking, but the more you do, the easier it becomes. And as we talked about before, you're going to be leaders in your society, in your community, in your world, and having the confidence to get on your feet and talk about something is actually a great, great skill. So if you feel like you want to be a presenter, put up your hand. There might be a couple of people doing that, or there might be also roles for answering questions. So you might have a couple of people doing the presentation and a couple of people all prepared with the questions that might come. All right, so decide on those roles early, but be flexible. Okay, so within the course of a week, we're going to go through the forming, storming, norming, performing processes. And the first that is forming, so we're orienting to the task. That's what we're doing now. At 3 o'clock, you'll be orienting to each other. You're coming into this as individuals, but by the end of today, you will be starting to think in a collective as a team about what we're going to do. Storming, brainstorming, that's where you're open to ideas. You're listening to what people are saying, you're chucking stuff on the table. Nothing's been ripped off the table. You're being supportive, showing tolerance, not saying, Jesus, that's a rubbish idea, let's get that off the table. Okay, that's good. Okay, we'll have a think about it then. We're so-and-so. So try and be constructive in that brainstorming space. That's got to be a safe space to put even weird ideas on the table. But then pretty quickly, by Wednesday, you're going to needing to be thinking about what direction your campaign's going to go. So you're going to need to start norming. And that's about cooperating and converging, saying what you're going to do collectively. And then Thursday and Friday, you are performing. You're polishing your presentations and you're giving constructive critiques. And you're also asking tough questions of the other teams. Put them on the spot. So you're performing in all ways. So it's a great process to go through, and you're going through it in a really condensed time. Okay, presentations. 15 minutes to present. 12 slides as a guide. Practice your timing. Now, you probably all know about how to pull PowerPoint slides together. Don't put heaps of writing on. Use big font. Brighten it with a few images, but minimise the kind of distracting animations and so on. So keep it fairly simple, but images and pictures can sometimes really help. 1 or 2 presenters, and this is the real challenge with presenting, is trying not to read and trying to tell a story, trying to engage with the people you're talking with, even though they're on Zoom and you're probably not even seeing them because all you're seeing is your slides. You're still trying to engage with them. So tell a story, build some passion, conviction, look straight into the camera. You'll notice people who, when they're interviewed on television and they're interviewed remotely, and they're not looking directly down the lens of the camera as if they're talking to the presenter at the other end, and their eyes kind of wander. It's quite distracting. So, focus on looking into the camera. Couple of people to answer questions, get some practice at that, ask each other tricky questions, and throw some curly questions at the other team. All right, and you get some vouchers if you win. All right, so here's your task, guys. This philanthropy, which I'm basing on the Maz Foundation, has a strategic goal to make a difference in the topic you have been given. They've already decided that illicit drug use or obesogenic environments or tobacco and vaping are what they want to focus on, and they've got $1 million to spend, and they want to make a real difference. And they want to make a difference to the occurrence of the problem, not patching it up at the end. How do you prevent this problem happening? How do you reduce the barriers to the solutions coming through? So your job, the board, the imaginary board that you'll be presenting to, will have medical people and non-medical people. So don't use big fancy terms, keep it in lay terms. And this board also has Maori and Pacific trustees, so you better be speaking to them about the equity value of your program. In reality, I think we do actually have a Maori or a Pacific person on each assessment. So we've got two assessors on the Friday, and one of them will be Maori or Pacific. So you need to make sure that you are covering that off. And so looking for the levers of change so that the problem diminishes. What they don't want is to fund campaigns that target the individuals that have the problem. They don't want the campaigns to focus on the people who are smoking or the people who are involved in intimate partner violence or whatever. And they don't actually even particularly want to fund anything in the healthcare services, because that's the job of the government. They want to fund upstream. That can be really hard to think through what that means and where you can find leverage. The things that kind of do have leverage upstream tend to be policies, or they can be funding allocations, and we'll come to some of those strategies. So they don't want public education, they don't want an app, they want something a bit deeper than that. All right, so when we talk about a campaign, I'm not talking about like a TV ad campaign you might see or something. This is like a military campaign or a political campaign where where the whole thing is totally planned. You've got your evidence, you've got your rationale, the aims, the target groups, who are the change agents, you know who your allies are, you know who the opposition is, you know what the barriers are going to be, you've got different messages for different agents of change. They might be parents, they might be local councillors, they might be school principals, they might be politicians. Who can change the system? Who's out there that can change the system that you want to get to? Different strategies and actions, which I'll go through. How you're going to measure success? How do you know if you're travelling? The timeline, so $1 million, that's not going to last you very long. Might be a couple of years, might be a few years. It's quite hard to run a campaign to change stuff for a real difference within a short space of time. You'll be expected to do a bit around budgets and an expected impact. So just to give you an example of a campaign that I'm involved with at the moment, which is really upstream. So I co-chair Health Coalition Aotearoa, which is an advocacy organisation of health groups, which aims to try to reduce the harm from tobacco, alcohol and unhealthy food and improve public health infrastructure and the determinants of health. So we have a sort of a mandate from our members to go out and advocate for various policies. One that we're involved with at the moment is around lobbying legislation. So a couple of years ago, end of 2022, Chris Farfoy, who is the Minister of Justice in the Labour government, resigned from that role and went through what's called a revolving door and became a lobbyist the next day, virtually. So he went from being inside cabinet, where all the kind of secrets of government and all the decision making occurs, and he was in charge of things like alcohol policy, for which he did nothing, and then went out into the world of lobbying on behalf of commercial entities to lobby the government to do stuff. So that's called a revolving door. That goes that way. We've got another revolving door that comes back this way. So Chris Hipkins, when he became Prime Minister, got a Chief of Staff. The Chief of Staff of the Prime Minister is the most powerful unelected person in this country. The person came straight out of a lobbying firm that had been lobbying for on behalf of alcohol companies. These are the commercial influences on our health. So When he did that, and there was a bit of hoo-ha, and Guy and Espiner did a whole series of broadcasts on this and exposed the problems that we have with lobbying in this country, you said, right, we now have what's called a political window. It opens and the politicians kind of get it, it lands on their desk. The Prime Minister was forced by all these revelations by Guy and Espiner to open the door and says, okay, the Ministry of Justice now has to do a review on what we're going to do about lobbying. So we as Health Coalition says, okay, now's the time to get a campaign. What are we going to ask for? So we had a hui, we had all the constitutional law experts and Sir Geoffrey Palmer and people that know about democracy and things, and we said, okay, what is our ask? What do we want? And we had a list of 3 things around commercial conflicts of interest, improving the Official Information Act, and having this lobbying legislation, which we don't have in this country, but other countries do. So what do? We have to get the evidence from other countries. So we fund a piece of work to Max Rashbrook to go and identify what other countries do to protect their public policy making against commercial lobbying. And so he went away and did that, and that cost a bunch of money, and now we've got that, and from that we extract what our asks are. And now we have to communicate that, so we have to fund a communications company to get the messages out there. We have to have spokespeople, we have to have messages that we're going to say. We have to go and meet with the Public Service Commission, we've got to go and meet with the Auditor General, all these people that have an influence. And how long is our campaign? Well, I don't think the Ministry of Justice and this government is going to do very much about it, so we're going to have to target the 2026 electoral cycle. So we've got 2 years of that. I'd like to have $1 million to be able to do that. We haven't got, we've had some money, but a couple of $100,000, but we don't have $1 million to do it. But that's the kind of thing that we're now running. And so it's getting organisations on board. How do we talk to the unions? How do we talk to other groups, the NGOs, the Forests and Birds, and all those people that want to get a level playing field? So that's kind of what we mean. We've done all of this stuff, the target groups, the allies, the messages, the strategies and the actions. It's a total military campaign. All right, creating the evidence base. I just talked about that. Build the relationships, the networks, who are your allies. Creating coalitions. As soon as the school lunch program looked like it was going to get the chop, Health Coalition went out and got some other allies, like the Children's Poverty Action Group or the New Zealand Education Institute. Get your allies that are going to work on various campaigns, develop the materials, disseminate the messages, draft up the policies, advocate for those policies, get into the media, build monitoring and accountability systems, influence organisational culture and systems. Culture. That's what Rawiri said. What's the culture of the organisation and how does that influence it? Cultivate the champions, training programs, and maybe some apps might be useful, but I haven't come across them yet. Anyway, these are not things that you learn in the hospital. These are the strategies that the population groups have to deal with. Okay, so have we still got that presentation? I think I did a presentation. Anyway, we can put that on Canvas about campaign details needed and the frameworks for creating the campaign. Presentations from 5 winners, I'd mentioned that, and that recorded presentation on Canvas. Okay, marking rubric is there, so if you, like all good students, you want to know how you're going to get marked, that's on Canvas. That's what the assessors will be looking at. Canvas tour, I don't know if we need Canvas tour, but what are the things I've missed out on? Okay, come up and remind them. Reminders from Anna coming up.
You have covered off some of them, so that's great. The main one for today is really get in touch with the agencies this afternoon. I've had 3 or 4 already come to me today saying, is this still happening? So it's really, really important you contact them today. Don't ask them to change the times either, because they've already come back to me changing quite a lot of times. So it might not be as convenient for you as you would like, but it's when it's convenient for the agencies. When you're having Zoom meetings, it should only be the people in the room who are actually attending the meeting. Don't have your whole team in the background. It's really distracting for the agencies. They've said in the past there's been a whole lot of students who weren't engaging and we felt really bad about it. You know, you weren't listening. So don't do that. Take your Zoom meetings somewhere else with the people who you're meeting with.
Which is rooms. You want to tell them about rooms?
Yep, we'll get to rooms.
Oh, okay.
Do keep checking the agency schedule, meeting schedule on Canvas in your team page. Again, I've updated, I don't know how many over the last few days and today, so things will constantly change there. So don't download it once and think that's it, because you'll likely miss something. You've said about, you know, these people are giving up their time for you. Be respectful. You're representing the university as well as the school, so, you know, act accordingly. There are rooms available for Auckland, you guys, through me. So if you want a room to work in or to meet in, let me know. Email me before 7 p.m. every day if you need them. But also be patient, because like Boyd said, it's just me and Boyd doing this, so there's a lot of you. There's also rooms for the other regions, but you need to contact the regional person, and that's on Canvas as well, so you can just go there to look for those people. Quick thank you to the Depression and New Migrants group, because I had to ask you to do something a bit early for an agency, so thanks for that. And the last thing is 4 prizes. Update your details on SSO, please, because that's where we send them. And if that's not where you want anything to go, if you're a winning team, it'll go somewhere else and get lost.
Okay.
Thanks.
All right, thanks, Anna. Okay, now I went over this with everybody in January, and I'm just going to do a quick flick through, but this again, and this is up on Canvas, but this is just models and paradigms, ways to think about it, structures for you to hang your campaign on, ways to see an issue. Don't forget all models are wrong, but some are useful, so choose the useful ones. And you may use, there may be one or more models to fit your campaign. So the Te Whare Tapawhā, we've already mentioned, it's already been used. Mataroria talked about that. The articles and the principles, these principles from the Waitangi Tribunal are an important way of structuring how you do things. Think about the patterns and the characteristics of populations. So this is the time course of COVID, as you will all recognise, and at different time points there are different types of strategies that work compared to others, so changes over time are critical. Thinking upstream, fence at the top of the cliff, all those sorts of things. There's a little YouTube clip here about the sort of upstream stuff, so if that doesn't, who keeps chucking these kids in the river doesn't ring a bell with you, just click on that. It's just a few minutes watch, and that's quite instructive. That story will stick with you. If you haven't seen it, boy, we've seen this a few times today, haven't we? This is the equity issue versus equality, what that means. So make sure you're bringing equity in. Everybody's got their different version of these cartoons, but they all tell the same kind of story. This idea about reducing, helping individuals deal with their health burden by helping them individually and reducing the slope of which they have to push their health burden up the hill. So this is the societal action, making things easier for people to make choices. You have somebody who comes in and you want to talk to them about diet and exercise and so on. If the conditions in which they live, if the neighbourhood is unsafe, if they don't have recreational facilities, if the place is filled with junk food outlets and so on, that's going to make their job really difficult to go out and eat healthy and do exercise. So we need both of these, the individual and the societal approach. This has been shown a couple of times already, the socio-ecological model. It's been around for a long time. This is just one version of it, 1990s version. It's been around since the 70s. This is a really, really helpful model to show that individuals and the individuals you see in your clinic and the wards and things are not just products of themselves alone and their DNA. They are products of the society around them and their upbringing and their parents and where they live and what country they live in, the privilege or lack of privilege they have when they're born and so on. So you know as doctors that when you see those individuals, they come with those contexts, and that's good medical practice, is understanding and helping them support those factors, bring the whānau in and so on. But it's still an individual-centric model. This is still putting the individual at the centre of the universe, which is not necessarily the approach for population health. So the Lancet Commission on Obesity that we did, we had this kind of model where actually right at the centre, the most important thing that we need to put our effort into is protecting our natural systems, because that's what we depend on. So that better be our top priority. And then out of the human-made systems, all these healthcare systems and food systems and education systems and things that we develop, the most important is the one right at the centre, the governance. Who's got control? Who has power? Who has money? Who makes the rules? And if you understand that, then you will understand why it is we have a healthcare system set up as we do at the moment, which is why when you go to your GP clinic, it's set up in the way that it is, or why we have our food system as we have it, or education or transport or whatever. It comes largely to this governance, and part of the governance is what are the mental models. We've got a government in at the moment that has a different set of values and therefore different mental models than the last one, and that leads to a whole lot of consequences. And we've heard a lot about the consequences at the just this morning around Te Aka Whaiora, disestablishing that. That's come from a mental model and an attitude about that we don't need separate systems for Māori because they can just keep struggling in the mainstream one. And then that leads to a whole lot of consequences. Anyway, this kind of system where you focus most deeply on those who have the power is probably a better way of looking at population health. The Ottawa Charter, 1986, first time kind of health promotion was really clearly articulated. It's an oldie, but it's a goodie. And, you know, these constructs are still valuable, although instead of reorient health services, it should be reorient your services more widely. But anyway, that's still a useful model. This is an example of program logic where you put your theory of change. So you want to change something. So you have a situation analysis, and then you create your priorities and your mission and your values and your mandate, and you've got your resources. These are the things you're going to need to be developing in your project, in your campaign. And then your money is going to go into something. And that is going to have some outputs, who you reach and what you do and what you create, all the workshops and the training and the educations and the writing articles and partnering up and so on. And then you think that's going to have some value in outcome. So this is called a logic model. And if you want to change anything on a big scale, you need to be able to think that through. So there's some examples of that. Systems thinking, I talked a bit about this in January. When we met, two things in this. One is that causes are loops. They are not point causes. They are not causal change that are linear. They are loops that keep progressing. And you heard some discussion this morning about these vicious cycles. So think about causes in terms of circles. And also, when it comes to actions, think below the surface to the patterns, the structures and the mental models, what's going on underneath. That's where we're going to force you to think. Somebody, when we presented earlier this year, someone asked about some references on systems thinking. So in Canvas, there are some references in there about why systems thinking is critically important for doctors, because you are operating on systems, within systems, on problems that have come from the wider system. You are immersed in systems, and if you don't understand what systems really is, then I think you're going to struggle to really make a big difference. Okay, social determinants report. This was the landmark report by Sir Michael Marmot talking about the social determinants, but there's lots of different types. I prefer to think about them as societal, which is a little bit more structural. This is saying, well, it's social, it's the people that cause it, but no, I think it's the structures that cause it, and the commercial and the political and the economic and cultural determinants and things, so have a think about that. Now, this is a big one. When you are putting together your campaign, the people who will be doing the action will not be fifth-year medical students. You guys are just the in-betweens. You've listened to the agencies, you've researched the problem, you're taking the case to the philanthropic board that $1 million is going to go to X and Y and Z to do all of these actions. You're just the intermediary. You guys are not going to do stuff. You're just planning this out. You're helping these groups of agencies or whatever plan this out. So don't put yourself in the action station. So if you're not going to do it, who's going to do this? And so when you think about how you get what's called collective impact, how lots of people work together to get collective impact, you have to have these 5 things. A common agenda, agree on what the vision is. You have to shared measurement, how you're going to measure results and work out how you're going. Mutually reinforcing activities. So you've spoken to different agencies. These guys are really good at that. Get them to do that. These guys are really good at that. Get them to do that. Have them work together. Number 4, continuous communication. That takes effort. That takes money. And then backbone support. Who's going to do the coordinating? Think about all that. They all kind of require some level of resource, but think about the actions in that way. And just finally, this was recommended to me, and I've just had I had a look at it over the weekend, and I think this is great. If you ask the question, why don't those people who have come in with this problem make more sensible decisions? Why do they choose to do what they did? Kids got asthma, come back into the hospital 3rd time, why are they not doing something about it? So this program is sitting on Action Station. It was developed by Jess Berenson-Shaw, who's a great communicator. She's an expert communicator, and she's developed this choices one. So I would really recommend that you go onto that and have a click on it, and that gives you a strong sense of how tough some of these personal choices are that people are facing, and they're not clear cut, and each of the choices has consequences. So I'd recommend that. Okay, so just finally, Tuesday to Thursday, 12 o'clock, one person. Got any content questions, ask the topic experts. Team management, development of strategy, ask the facilitator. Any student absences and so on, email both Anna and I. And above all, guys, enjoy it. This is pressure cooker stuff, this is big stuff, this is new stuff, but you guys are really smart, and I'm really looking forward to what you're going to have produced at the end of the week. So go forward and have a good time, guys.